Okay, folks. Well, good evening. Thank you for joining. So I'm Steve. I'm going to be sort of running the session tonight in and around sort of patella tendinopathies. We're going to go through pretty much the whole plethora of assessment through treatment, through rehabilitation, and then just talk quite a lot about some of those kind of common trends that we see, really. So I know there's things like treat the donut, not the hole that gets thrown around. It's kind of treating the good bits of the tendon. So if you have a degenerative tendon that you potentially have issues with, or there's areas that are sort of full of ground substance, etc., that aren't as contractile, there's not as much collagen in there, then you're not going to get as good a response. But what we're going to do is hopefully give you a bit of a guide of kind of how to go through assessing this and see sort of where people are at when you've got patients or athletes, and then almost look at how we build up from there. So we'll go through some of the treatments that I've used within rugby, within judo, within kind of gymnastics. And we'll talk quite a bit in and around sort of analgesic load. So there's some really nice ways that you can load a tendon to give you sort of a 40-minute little window where the tendon isn't as sore. So you almost drop the pain levels that might allow them to rehab or train. And basically you're trying to make some significant changes over time within there. Now we'll talk about the timescales as well. So obviously kind of from a timescale perspective, it's very rare, isn't it, that we have a patella tendinopathy that we just calm down straight away. But there's certainly some really useful things that we can do that are kind of easy, quick wins, common sense wins. And then we look at sort of almost how to build them through that process so that it doesn't recur again. So what I'm going to do, without hopefully this crashing, is go through and I'll play you the assessment part to start with. And then what I'll do, just to kind of give you a little bit of clarity, is come back together again. We'll have a little sort of get together so you can ask any questions if you want any additional clarity, and then we'll go from there. So enjoy the first part. Apologies for the late start again, and enjoy. Okay, guys, welcome back. So I'm Steve Miller. I am the founder of Grow Physio, and I want to welcome you into this to talk about patella tendinopathies today. So by the end of this, hopefully you will have a pretty apologies, guys. Whenever I click on chat, there must be some sort of glitch within Zoom. So I'll just not do that. Was that coming through okay? If someone can bang the microphone and just say yes or no. Yeah, brilliant. Right. Yeah, I think there must be some sort of glitch on Zoom. So what I'll do is I'll just play this and then not interrupt it. Hopefully that means we won't have any errors. Okay, guys, welcome back. So I'm Steve Miller. I am the founder of Grow Physio, and I want to welcome you into this to talk about patella tendinopathies today. So by the end of this, hopefully you will have a pretty good idea of some of the different things that I would consider when managing a patella tendinopathy, how to assess it, what things to look for, and then eventually in the second half, what we'll do is look at all the sort of management strategies related to this. So over the next hour, what we will look at is the anatomy and some of the criteria that you need to hit. It's fairly easy to diagnose a patella tendinopathy. The slightly tricky bit is maybe sort of working out why it's occurred, what you need to change, and how to manage that accordingly. We're going to try and reframe the tendon into a spring. So again, that sort of energy storage system that you can have. What the typical mechanisms and onsets for the development of a patella tendinopathy are, a lot about load management and some of the other intrinsic and extrinsic factors. Then we'll have a little look at the practical side of things. So what would I look at within my clinical assessment to try and diagnose it, look at what their capacity is like in that tendon, and so on. You'll need to understand the tendinopathy continuum, and then again, what we'll need to do is address all those contributing factors. So this is the anatomy really, isn't it? So the bottom base, that sort of distal area of that patella is where your patella tendon starts, and then it attaches into that tibial tuberosity. The more typical region that tends to become sore is that inferior pole of the patella, and more often than not, the pain comes when it is loaded through that, the knee extensors or the quadriceps specifically. You'll usually find that the pain equates to the amount of load that is going through the tendon. But again, that is an interesting concept, really, because we're going to talk quite a lot about analgesic load later on and how actually loading can make the tendon feel considerably better. Now, there are 4 key prime hitters in the world of tendinopathy management. There is Peter Malliaris, Jill Cook, Craig Purdom, and Ebony Rio. Any work that they have done that you want to go and look at around this is certainly going to improve your understanding of tendinopathies in general, and particularly sort of patella tendon and some of the discrepancies between the patella and the Achilles and the glute tendons, hamstring, proximal tendons, etc. Now, patella tendinopathies are pretty common. They occur within about 2 to 5% of the athletic population, and again, understandably more related to that explosive transfer of energy. So the jumping athletes, recurrent jumpers, will tend to be affected. So we've got 32% of basketballers, 44 to 45% of volleyballers at some stage in their careers will have a tendinopathy in their patella tendon. Now, this is where I want you to kind of almost imagine the tendon as a spring. So it's an energy store. Your patella tendon is a short, broad-based spring that basically, through its motion, will go through this. So it will create or generate force, but then similarly, it will also have some absorption properties at the same time. So what I want you to think is, again, in that shortened position that it is in at the moment, what that has is a lot of energy that it can propel and force you up into running, into jumping, be it vertical or horizontal output. You need to generate the stiffness in that tendon in order for it to function effectively. If you don't have enough strength or output really going through it, or you spike that load, what you may end up with is something like this on the right hand side. So it can become a little bit disorientated. If we think about the sort of energy storage on the left hand side compared to the right hand side here, obviously on the left hand side there's a lot more stored energy compared to the right hand side. Any disorientation, any sort of disorganization within that tendon, that inability, or if you stretch that tendon, potentially what you may do in actual fact is reduce that tensile energy store that you have within there. And that's really important, isn't it? Because the tendon has a heck of a lot of demand through it during certain activities, usually jumping, as we see here. So we've got the basketballer coming across here, thinking about the vertical output through that body, as well as the horizontal forces. Obviously, something like a tip-off, very vertical. But again, what can happen with tendons is you can have that recurrent volume cycle where they are practicing again and again and again in order to try and make their free throw or whatever it is that they're doing in practice. So the volume or the number of repetitions that they have can be a massive factor in terms of increasing the load going through that tendon and eventually causing 2 issues. Now, if you aren't familiar, I would certainly have a little look at Tim Gabbett's work. We talk about this a little bit in the hamstring course. So if you want to go and check that out, you can do. The acute to chronic work rate ratio is a really important thing to consider with tendons specifically. So we have a positive effect, don't we, from loading up tendons. As long as it's incremental, it's within the capacity, and we slowly push that envelope of function that Scott Dyer talks about in there. However, if we go beyond that into that sort of red danger zone, if you want to call it, where there's an increased risk above that 1.5 on that acute to chronic workload ratio, the risk of flaring, particularly tendinopathy problems and flaring up the tendon, ramps up considerably. Obviously, there's lots of other factors that can feed into that. So it might just not be one dimensional thing. It's bound to be various different multi-dimensional components that feed in that. So what are they? Well, we've got the intrinsic factors. So what is that? That is basically everything that applies to that individual that they have very little control over. So it might be their age, their gender. We know that athletes who are a little bit older will be more susceptible to degenerative changes. They probably do less loading in those positions. They may have had some other factors such as previous injuries, maybe restrictions in ankle range of motion, hip range of motion from previous problems that they've had. Extrinsic factors are the things that really you need to kind of really quiz and understand your athlete and the sport that they're in. So you very much need to try and control the load and work out what it is that the aggravating factors are, how much they're doing, what was it in that session that they specifically did that caused them to flare, or actually was it a build-up of a lot of different things over a period of time? Has it changed in the gym? Has training intensity been a factor? Is the schedule of fixtures a factor? Is the surface a factor? Lots of different things that you need to consider. And then we have sort of systemic problems. So again, some athletes may have some underlying medical conditions, maybe diabetes, maybe sort of almost thinking about weight-related things, adipose tissue, things of that nature, really. So again, lots of things that can feed into that tendinopathy. Good, again, to get your little hat on and quiz people a little bit further. So again, just to touch on that, so an older athlete, although we generally tend to work with athletes who are competitive in terms of playing, you may be seeing older athletes in your world. So again, you normally see them in younger ones, but actually as they get a little bit older, you're going to have degenerative changes likely within that tendon. You might have acute on chronic conditions that start to flare up. It's usually a little bit more common in males. And again, thinking about how we measure the amount of load. This on the second picture here, you can see we've just got a live update really of where the players are during a training session. So on the top, it's the heart rate. And on the bottom, you've got that GPS units that monitor the distances, the acceleration meters, the decelerations, the changes of direction, the volume, sprint meters, etc. So again, if there has been a trend across the team or in that individual and they have spiked their load, that is how you will potentially get some of that raw data to discuss with strength and conditioning staff, rehab staff, maybe with the coaches to look at the amount of time that they're on feet. The other things that are worth thinking about, again, are the output of that knee or patella tendon. So a long jumper, clearly that is a very high jump that they are producing. So there is certainly vertical output. The reason I picked this one, though, is for that horizontal output that's there. So again, what is the takeoff leg that they are generally jumping off? Is it that one or is it the other one? Compared to maybe something like a tip-off in basketball, or it might be those sort of small constant bouncing that they do in these martial arts sports. So karate is a classic one, really, where they are just constantly bouncing up and down, kickboxing, etc. So that repetitive low level bouncing plyometric load can certainly irritate that patella tendon or certainly cause an increase in the volume that's there. And again, thinking about the sort of epidemiology, the prevalence, who does it occur in? Well, generally activities that are explosive, involve cutting, change of direction, jumping athletes are the ones who are most vulnerable. What do I normally see? Well, quite often when you, again, pick into the history or look a little bit further in depth, there's usually been a period of deload, maybe another injury that's possibly occurred, maybe some off-feet training that has occurred that's maybe sort of to try and protect somebody, or they've had an off-season and then they're getting back into pre-season. That ramp up again tends to be the time when people flare. The age of them that I tend to see is sort of that 15 to 30-year-old that are reactive tendinopathies, which we'll talk about in a while, versus your older ones that are a little bit more degenerative. And again, why? So again, we're trying to work out, is this something that happened in one session where they were out there for 3-4 hours training until they got a certain move right, or they were doing a line out over and over and over again? Or is this something that over the last 4 weeks or few months has actually sort of almost ramped up considerably in recent times? I think it's a little bit misleading sometimes when we have patella tendinopathies and tendon issues in general, particularly the patella, because it's often very sore as they do the activity, but then they often find that afterwards they're not too bad. As soon as they then go back into it again, though, it's that sharp, irritable pain that they get in the patella tendon. So they can often find little ways to do these activities without necessarily putting as much load through that patella tendon. So they might use the other leg more, they might weight shift a little bit more, they might have trunk compensatory strategies, etc. But it's really important because actually, Jill Cook, again, in her study, looked and actually there was a lot of individuals who were potentially unable to return to their sport for 6 months if it involved those sort of more explosive jumping sports. And up to 53% of athletes were forced to retire with a patella tendinopathy. Now, obviously, that is very dependent on the individuals that you work with and the sport that you're in, but it does highlight the importance of getting these right. And I can echo that. So when I worked in beach volleyball and indoor volleyball at London Olympics, this is what we tended to see. So we did have a lot of patella tendon problems. And again, just as a little bit of a snapshot on the bottom left-hand corner there, if you look at how many athletes in there are wearing patella tendon or knee supports, it's probably testament, even at a lower level, how many people end up with knee issues and patella tendon problems. On the right-hand side, yeah, again, you can sort of see that's me with the Team GB that was there. And yeah, again, sort of does the surface have a bearing in terms of the indoor versus being on sand surface? I would say that we generally tended to find that there were more when we were on a hard surface than a sort of softer surface. Whether that's due to the impact and the load, not really sure. That's not the only reason that it can occur. Obviously, you can come down and land onto your patella tendon. This athlete on the left-hand side, we had an acute on a chronic sort of flare of a tendinopathy around that patella following an impact from a player. So on the pitch, when we assessed him, basically he had a massive quad lag. He was really struggling to get that quad to fire again. So he had that inhibition that was there. And again, that poses a bit of an issue. So we were in a sort of a defensive play. He's desperate to get up. The coaches are screaming at you to get this player up and about. Are they functionally stable? Yes, they are. But actually, sometimes what you need to do is fire up these quads and get them woken up again before you let them go out. Because actually, their risk of injury is huge if they can't contract that quad properly. So I just want to take you through the tendon continuum, really. So this could apply to any tendon that's here. Typically what we have is a fairly normal tendon. So if we start in the middle, you can have different phases of reactions that occur through that tendon. So if you overload it, let's say we have too many sprint meters, someone goes and does some hill sprints. Maybe they've done a lot of jumping in a training session. Maybe they've had an off season and then they come back in again. What can happen is that tendon reacts. So then it goes in towards what's called a reactive tendinopathy state. Now, what you can have in that scenario is you are just a little bit clever. You box clever, you reduce the load, the irritable factors that are there, you calm that tendon down, and it turns back into that normal tendon. Should be a little bit of a wake-up call that you then go to the right-hand side, and actually what we need to do is optimize the load going through that tendon. So again, the tendon loves loading. It doesn't particularly like stretching, and we'll talk a little bit more about that later on. But again, if we can incrementally build the load, and athletes like this, because you want them to go heavier, is optimize and load that tendon. You get adaptation, strengthen it, and hopefully it becomes more robust. Now, if it goes the other way, so we go from a reactive tendinopathy and we keep on stirring up that tendon and we don't allow it to settle, maybe it's just being massaged, we put a tendon strap on it, something like that. It might help it a little bit, but fundamentally we keep on stirring up that tendon. What can happen is we head towards the tendon disrepair phase. Now, what happens there is you start to get changes within the tendon itself. So what we start to get is some disorganization, really, of the collagen that's in there. And you start to get development of some ground substance that starts to come in from there. So the collagen makeup of that tendon can change. Now, if that continues, what we can end up with is a degenerative tendinopathy. Now, once it gets to that stage, again, it's not the end of the world. There's still a lot of the tendon, hopefully, that is still healthy, that we can work with. But again, if we get to that phase, there are going to be probably some irreversible changes. But that is not to say that actually there is still a lot of that tendon that we can still hopefully work with. Now, what can happen, and we'll talk about this sort of carousel of sadness that I've sort of mimicked later on, is if they have a reactive tendinopathy, it becomes sore. They then deload themselves, they rest it for a few weeks, go back to whatever activity is in more of sort of an amateur sport sort of level. That weekend warrior kind of thing is a classic sort of example. What they do is they then shield the tendon, it becomes weaker, deloaded, and then all that happens is then when they go back, they have even less capacity than they did before, and then that will flare again. So that is some of the work from Jill Cook and Craig Purdom. So again, have a little look at that in the British Journal of Sports Medicine in 2009. So again, the ones that tend to come back to me for a specialist opinion on why it is potentially being an issue is that tendon has generally been deloaded, or it has been sort of completely reduced load going through it for a period of time, maybe on a cycle where they've had a few breakdowns with it. And all that's happened is the capacity of that tendon after an injury has just reduced gradually. So the strength that was there, maybe even when it was originally injured, it's even less than that now, and they haven't regained that properly. They will present with pain. There'll probably be some pathology. It's often reactive, or it's reactive on a degenerative tendon, and they may have or may not have had some imaging. Usually the imaging has been fairly normal. There hasn't been particularly big tears or significant tears in it, but the tendon just remains painful when they go back to their activity. They always ask the question, well, is this tendon vulnerable to rupturing? I know someone who's another athlete whose tendon ruptured at their Achilles or the patella tendon. Is mine going to go as well? Well, actually, you can reassure them that quite a lot of the time what we have is a degenerative non-painful tendon with good function. Yes, it can, but it is incredibly rare. So in the general population, you're looking at 0.68 per 100,000 people. I would suggest it's probably even lower than that, to be honest, unless they're doing something significant, versus Fredericks et al.'s study last year, where 6 in 100,000 people who were military recruits. Again, lots of jumping, explosive activity with bags on their backs, all that kind of thing. So it's incredibly low levels with this. In terms of imaging, again, some people will be quite frustrated. They want imaging if they haven't had some already. You can reassure them, again, that the findings on an ultrasound, which is the usual go-to to start with, are usually indicative in healthy and unhealthy tendons, whether or not they are pain productive or not, that you are probably going to have some degenerative changes in some of them. There may be some little micro tears that are there, some ground substance that may have built up. There may even be some infiltration of neovascularization, should I say, that's in there. But again, an image isn't the be all and end all in terms of working out what's going on with this. You should be fairly confident that there is a patella tendinopathy going on. The reason that I would potentially do an ultrasound or an MRI scan is really to try and work out whether the fat pad or the infrapatellar bursa is affected as well. So again, that might be more of an indicator that affects the patella translation up and down. If there's swelling underneath that kneecap and that patella can't descend, then what you may have is some altered mechanics that are there. You might also have some loss of knee extension that you'll have to restore. So again, the imaging side of things, it assists your clinical diagnosis and excludes other pathologies. It's very likely that you're going to have some coexistence potentially of the infrapatellar fat pad when you look at where that is, and maybe the bursa that you can see on that imaging there. At the bottom, that sort of fire in the tendon, again, I probably wouldn't show any of your athletes this because it looks a bit aggressive, but it's just picking out areas of potential sort of vascularization, so blood flow into the tendon itself that shouldn't be there. And there may be some neural growth that's going on within that tendon itself. So again, they then become a pain source in themselves, really. But again, sort of, there are partial tears that are pretty common on ultrasound, and it doesn't mean that that is the end of your tendon, nor is it going to potentially rip in half. So again, just on that sort of neovascularization and neural growth, again, sort of you can see it a little bit more detail here. We, again, sort of far too creating a picture, becoming a little bit more sensitized to that region. It potentially starts to listen a little bit more to that area, the more pain and the more recurrent you are, particularly if you have an athlete who is concerned about any of these things. So again, that education side that we'll talk about in the second half, really, really important. Now, on that education side, what is often a bit of a disaster for you is if you get this imaged and the report comes back verbally as them having a hole in their tendon or multiple holes in their tendon. So I think in the bottom middle is basically exactly what one of our athletes envisaged that they had in their patella tendon when they had a tendinopathy issue and went to go and get it scanned, and that's how it was relayed. So they imagined they had a hole. It was basically pretty vulnerable to falls, collapsing, potential ruptures, etc. It's not a good image to have, really, because in the top right hand corner, all they're going to think is that, well, the natural progression for that is that the wall falls down or we basically rupture our tendon. So what I want you to do is try, and this is something that I've used, you might have your own ways of doing it, I really don't mind. This is something that I have used to sort of frame that, really, and use a rope analogy. So on the left hand side, look, this is a picture of a rope. This is a little bit like your tendon. Imagine that you have some fibers that are damaged within there. Is that rope still going to be strong even if you took a couple of those little strips out? Most of the time the athlete will say, yeah, looks pretty solid. Okay, great. So actually what we need to do is not panic too much about this. There's still plenty of tendon that's intact, plenty of it that's looking after those slightly degenerative or changed areas. And then actually in the middle picture is another one that I use. So would you rather have a pretty narrow tendon or would you rather have a stronger, more robust, thicker tendon? Well, that then creates like a little bit of a, oh yeah, I would rather have a thicker tendon. Then you might have to go into the, well, actually, if they have a thicker tendon already, that might actually be indicative of some pathology that's there. So classically what we find is that the body will try and create a thicker tendon in a pathological way because it's trying to cope the best that it possibly can with the demands going through it. However, this is where you need to be a little bit clever and say, well, actually what we need to do is it may be a little bit thickened, but it's not actually stronger and thickened. It's trying to reinforce itself, but not in the most positive way. However, what we need to do is actually build the strength, the load, the capacity, and match that to what you're going to go back into in order for you to cope. So yes, we will create potentially a stronger, thicker rope that you see on the right-hand side, but actually it may not visually look any different. Then I would probably go on to, well, actually around that, if you have the quads, would you rather have some massive quads that are looking after your tendon so there is more load going through your muscle, or your tendon? And again, they say, yeah, well, I'd rather they went through my quad. So again, the loading, the strength benefits of loading through your quads and getting your quads as strong as you possibly can will naturally increase the amount of load going through your tendon, but again, might act as a little bit of a defensive wall from there. What you don't want to do is almost imagine this. So be careful that they do not think when they think of a rope analogy that may snap, that you're on your last final little thread of rope that's there. Definitely go with the former. So not this one and more the above one that's there. So then they say, well, how do we do that? What do we do? Well, this is where we go, really, isn't it? So we may, from a tendon that's maybe flared, go to some appropriate loading strategies. Again, keep it incremental. What can they do? Is there anything in a reduced load capacity while it is maybe settling down that we can still do without flaring it? What we don't want are surprises, spikes, massive ramp ups in load in various different ways, speed, jumping, explosive activities, landing, etc. And if we do that, what we will get is some positive adaptation in that tendon. That will then, from a strengthening process, start to respond positively. And then what we will hopefully get is that tendon returning a little bit more to normal. And again, this is something that I use quite a lot, my own little sort of take on this, the tendon carousel of sadness, I call it. So someone comes with pain in their patella tendon. They then have rested it or they've deloaded it enormously. That pain is often settled, doesn't it? So again, as they deload it, the pain starts to reduce. They feel a little bit better. But what's happened through that process, typically, if we haven't managed them appropriately, well, all they've done by deloading it is reduce the load going through the quads. They've become weaker. They've become deconditioned. They haven't got the specificity anymore to what they're about to go back to. They may well have even tried things like massages or stretched it or rubbed the life out of it, which we know that tendons don't like compression or stretch. So we want to try and avoid that at all costs. There isn't a great deal of compressive structures around the knee compared to the elsewhere in the body. But again, what they've done is they have less of that stored energy and strength But they go back to training, and then they go back to a similar sort of load, which is beyond the capacity of that tendon, and they just end up breaking down again. So they go back to pain, they then rest it, the pain settles, they get weaker, they train again. So in essence, all that's happening is they flare, they rest, they then go back, they flare it again, they rest, they go back, and all the time that this is going through this process over months and months, all that's happening is they're finding different ways to move, and they're deconditioning, and the strength going through that tendon is reducing. So this carousel is something that I often talk about. So what do we need to do? Well, we need to start to train the donut. I think the original sort of quote was to treat the donut, whereas I sort of reframe it as train the donut, not the hole. So again, this sort of work from Cook and Purdom, an amazing read, certainly pioneered all of this kind of thing. But what we need to do really is expose it to load, get that sort of tendon exposed to strength training, be clever about how we do it. So again, we may need to find isometric activities that we do and hold them for longer, maybe do them less often. But again, what we want to try and do, and athletes love this, you're telling me that this is painful, but you want me to load it? That's exactly what I want you to do, but we need to be a little bit clever about how we do it. And the common thing that I find is that actually a lot of the time the tendon is underloaded. So as I said, if you underload the tendon so it doesn't have the strength capacity back in it again, what you're going to find is that it can't cope with the demands that go through it. There are huge amounts of load going through your patella tendon during certain activities, hopping, running, jumping, etc. And if it isn't strong enough, not robust enough, you will break down. So people might have done hundreds, thousands of the activity on the left-hand side. They might have done leg extensions with no weight till the cows come home. But actually what we need to do is shift to that heavier weight, that heavier load, and work in the appropriate ranges for that individual. The other things to consider is whether you go open chain, obviously you reduce the body weight going through it, versus an open versus a closed chain activity where there's body weight going through. So actually a lot of the time they ask you, well, I'm still getting pain in it, I've still got a baseline of sort of 1, 2 out of 10, is that okay? That's absolutely fine. A lot of the evidence that's come out from Silber-Nagel and Kongsgaard and all the tendon gurus is actually what we need is a low level baseline often of pain. That is totally acceptable going through this. As a bit of a guide during activities, I don't mind them going up to sort of a 4 or a 5 out of 10 on that numerical pain rating score or visual analog scale, really, as long as it drops back down to their baseline after that. Now, again, 0 to 3, if it's really low exposure and they aren't getting any sort of ache or anything afterwards, you may actually be underloading that individual. So this is often a little marker that I use to teach the athletes, if they are going away to do a loading program, to self-monitor how they do that. So again, up to about 4 or 5 during an activity isn't too bad, as long as it drops back down to sort of their baseline afterwards. But if it's getting up to sort of a 6 to 10 out of 10 on that sort of scale, that really is probably an indicator that you are flaring that tendon. There are some studies, again, Kongsgaard has pushed this out a little bit more, really. He doesn't mind that maybe going a little bit higher, as long as within 24 hours things have settled back down again. So little depending on the athlete that you're working with, maybe recurrence, how often it's happened, what their sort of biopsychosocial model states are, whether they are catastrophizing about it, whether they don't want any pain, etc. All of these things might just sort of feed into how I manage that individual. But again, loading it can actually have an analgesic effect onto that. And what do I mean by that? Well, actually, it can reduce the pain. So they've done some really good studies looking at loading heavy at sort of 70% of that maximal voluntary contraction, and how that can create about 45 minutes of significantly reduced pain through that tendon. We will talk about all of this in the second part when we talk about managing it. But again, we're going from a fairly low level where it's athlete led quite a lot of the time in terms of how far they push or how hard they push into something like a Swiss ball, like a core stability ball against the wall. They can self gauge how much load they're putting through that.
Again, you can use things, bits of kit in the gym are classics for this. Leg presses are ideal before you maybe go into something like a sort of a free weights environment. And that can have a massive bearing on the amount of time that it takes for that tendon to warm up. So the typical thing that they tend to report is actually, or the things that you tend to see, is the athlete is on the side of the pitch. They are often rubbing their tendon. They're trying to do some little heel flicks, stretching their quad, rubbing into their quad, etc., and trying to almost breathe a little bit of life into that tendon. Once the tendon gets warm, they're normally not too bad in the early phases of a sort of reactive tendinopathy, but afterwards it tends to be quite sore. Gradually, as they go through that sort of almost continuum that way, if they get gradually worse and worse, so if they become reactive, keep stirring this up, maybe going into that disrepair phase, and they carry on training through this, what they will find, it will take longer and longer for that tendon to warm up. They may even be sore through it. They may just find that their performance is significantly affected. What you might find is actually doing some of that heavy loading we talked about before, creating a window of sort of up to 45 minutes where the pain is less. They might find that the warm-up that they need to do feels much better. They can do what they need to by doing that prior to a session. And actually that has a massive bearing. And then when I talk about the sort of performance factors that come in, these are things that they would often describe to me. They're just less confident with that knee. So when they strike the ball in football, their power's reduced. They don't do as many long range shots, passes, etc. And they tend, even on analysis, it might be picked up that actually they're not going forward as much. They're playing safer. They're passing the ball to the side rather than those sort of defense splitting passes in football that you find, or actually they're winning less headers because they can't actually jump as high, or they don't feel as confident on it. The other thing is just, again, reiterate that stretching this tendon is not the answer for them. If we think about that spring analogy again and go back to that stored energy, if we stretch the spring, that recoil that you have in it is going to be significantly reduced. It may be feeling tight. It may be totally counterintuitive to load it, but get them to give it a go. If they are adamant that they want to do it, again, we'll talk about this in more detail, but they may want to roll or trigger or use a Theragun style thing or massage into their quad, or certainly work into that sort of hip flexor stretch position to take a little bit off the rec fem potentially, but try to avoid them doing that sort of classic knee to bum stretch that you see there. So that'll hopefully give you a little bit of a background to it. Now what I want to do is just almost again delve into that subjective. So what will they describe? So as we said, jumping, plyos, explosive activities sore, kicking sore. It's taking more time, physio, to warm up. It's painful. Once I stop and then have some food or get changed or jump in the shower, sit down and then get back up again, I just feel awful in the front of that knee. That patella tendon's pretty sore to touch. It may well have a little pocket of fluid if that sort of infrapatellar fat pad is affected, but often they stick their finger directly on it, pinpoint, and just say, you know what, that patella tendon is really sore. They may find that it's incredibly painful to squeeze it. So again, relating back to tendons do not like compression or stretch, so it may well be painful on either of those. They may also be describing a bit less confidence, so that pseudo giving way. So again, that inhibition that you have, that little jarring of the knee, just when those quads switch off really. They've gone, oh, I've been to see somebody, I've stretched it, I've had my quads massaged to high heaven and nothing's made really any difference. And again, delve into that loading history. What have they been doing over the last month? What have they done in the last week compared to the last sort of 3 weeks? And then what's been happening in the last sort of 24, 48 hours compared to maybe that time period as well. They may well have a bit of a quad lag if this is really sore. And again, mornings may a little bit less so than you would find with a Achilles because of that shortened position, but they may find that they're a bit sore in the morning. These were a couple of the classic sort of things that we saw. So with our patella tendon flares, these were the classic reasons. So it was always the second rowers jumping, trying to practice their line outs over and over again till the cows came home, till it was nightfall and dark and everyone had gone home. They'd still be out there with the floodlights on trying to perfect their line outs. So again, the amount of repetitions that they did was a factor for the jumpers, particularly the sprinting bits and pieces. So again, as We went into a period where we tried to protect hamstrings quite a lot and really kind of built up the load in terms of the sprint meters, or open things up from small games into bigger environments. That was causes for flares, particularly in sort of training. You want to try and mimic the demands that you would get in a game. So the first few games, a lot of people would then find that there were issues. Other things that happened, we had a great bloke who went and played sevens. So we were playing 15s in rugby union. He went to sevens. There's obviously a lot more space. It's a lot more sprint meters. It's far more open. They are constantly for literally 7 minutes running like the clappers after against each other. So there's loads of accelerations, decelerations, loads of opening up meters. So again, they will potentially run far further before they hit a defender that way. Other things that happened in pre-season, everyone would get this great idea that they'd go and do some hill sprints, and then they'd come in with their patella tendons pretty sore, so all that load going through the front of the knee. And then I guess the only other thing that we maybe had were some bits and pieces potentially from jumping from different surfaces. I think foot and ankle problems and hamstring issues were way more of an issue when it was found in the RFU PRISP study. That was there, that we found that there was a lot more of those issues than patella sort of knee problems. But maybe the surfaces that you're on, if you're swapping from indoor to outdoor, from Astro, 4G to real grass, they might be factors in terms of what's going on. And the other things that I would always ask is the S&C staff or them directly, if they have taken up some new program, how do they squat? They say they squat, but how do they do it? What are they doing? What's their form like, etc.? And are there ways that we can keep them loading, but is there a change that's put more potential load through that tendon? It might be that they're doing box jumps, for example, with load on their back or no load on their back. But again, it might be that they're doing things certainly quicker or to a greater depth that might be having a bearing. And again, I've just put this on here for reference, really sort of thinking about that patellofemoral, patella tendon region. The load that goes through some of these athletes during these activities is massive with certain things. Obviously, when we go to plyometric activities, hopping, jumping, etc., that ramps up enormously. And also little things just to kind of just check on, really, is the calves, to make sure that, again, if their calves are tight or their ankles are particularly stiff, what bearing is that going to have? So when we look at the move, potentially on a treadmill or when they're playing, are they having an early heel off because that calf is particularly tight? And does this correlate with something like a knee to wall test, where we look at the mobility that they have in that calf and ankle complex? The other thing that we had in rugby, which you will also have in football, is you have different kickers. So again, rugby union's interesting. Which type of kicking is it that's particularly sore for you? Well, we used to find often that the kicks off the tee were considerably worse, or if they were kicking for distance, it was a lot more painful because there was a lot more load going through it versus something like a restart or a drop goal. And if you do work with footballers, again, things like free kicks, absolute worldie of a free kick here from Roberto Carlos, but as he impacts into the ball, obviously the load going through that tendon is enormous. So again, he's never going to strike that if he's not particularly confident with that. And again, let's have a little look at the objective. So we've kind of looked at some of the clues that you'll find within that subjective. Now let's have a little delve into the objective really that's there. Now, have a little look on the anterior knee, the patellofemoral video, to familiarize yourself if you need to with the anatomy, or it's on YouTube. Just Google or look into YouTube at Grow Physio's website and have a little look on there on the channel, because there are other things that can mimic pain around this region. It's usually fairly straightforward. It's painful on compression of that inferior pole, painful to squeeze, painful on contraction of the quads, but it may be coexisting with other factors. And you can see the fat pad that's there in pink. Big structure, sits directly underneath the patella tendon. You also have some other bursas that are there as well, but the fat pad being massive and the most pain sensitive structure in the knee, according to Scott Dye, it's no wonder that it's pretty sore. It sits right underneath there. Whenever we contract the patella, no doubt it starts to compress into there a little bit. So again, you can have coexisting pathologies. And why is that important? Well, often when we come to testing, in those sort of extended knee extension positions. If we hyperextend or in that terminal extension position for the athlete, that will potentially nip onto the fat pad. That's usually the fat pad that's sore rather than potentially the tendon. In terms of other things, there's very rarely swelling when you have a little look at these, unless there's a bit of boggy swelling in the bottom, which is usually that sort of fat pad or infrapatellar bursa that's there. But yeah, because it's not internal within the joint capsule, that would be your meniscal, ACL, PCL, etc. in there. That was a bit flared. So you don't often see any swelling as an effusion, but you may get a little bit of bogginess from a coexisting structure, or you might have thickening that's muddying the water a little bit of that tendon, which usually, if you measure the width of it, either with your fingers or with something to measure, or you find that on an ultrasound when they compare the width of it, it may be different. That's usually pathological. So they're changes that the body has tried to lay down more tissue to cope with demand, but it just hasn't worked because they've been on that sort of sad cycle for quite a long time. I would always obviously assess the amount of knee extension power, and I would also look at that at different ranges that are there. So on the left-hand side, you can see not in full extension, but probably in about sort of 5 degrees of flexion, testing the resistance that's there. Then going into sort of 30 degrees, maybe into 60 degrees, and then sort of 90 degrees. You'd usually find from experience 90 degrees, so you basically got that quad sort of in its outer range, and then contracting often puts a bit more stress through that patella tendon. So just to show you what that would look like, again, I get them to actively do it themselves to start with, and then just resist. Take them back down, again, resist isometrically. You either get them to push up into you as hard as they can if they're apprehensive, or can you hold this? Can you hold it for 5-6 seconds? Don't just leave it on there for a second or two. Literally make sure that they can hold it. Then what I do is almost just instruct them to take the leg up, but they're pushing out against me. So I would check the isometrics and then look at the concentric load, and then I'm going to get her to eccentrically control that back down. So I'm pushing quite hard down through there, and she's just resisting that movement right the way through range. So again, if they were sore on some of the isometrics, I probably wouldn't start ramming that as hard as I possibly can, but it will give you a bit of an indicator on some of those less flared up tendons, another little sort of realm to delve into. Again, it's really important to get objective markers with this. So if you do have a handheld dynamometer, you can do that manually with yourself. Either position your elbow against a wall so you don't get thrown by some big, strong athlete somewhere. So yeah, you're kind of resisting there. If they are incredibly strong, you have the access to a little mulligan belt or something of that nature, then what you can do is use that handheld dynamometer, put it in front of their shin and get them to push out maximally, and you'll get a marker in regard to how their output is. So again, you can compare that to the other side. You can compare it through the rehab process and see how they're getting on. And again, just be consistent with where you're, with the angulation that you're doing that. If you have access to a dynamometer, something like a Biodex, then you could potentially use this. I wouldn't use this as part of my initial assessment because it's probably just going to flare that individual, but it will give you an additional marker if you need it. Other things I would look at, again, are looking at some of the restrictions around this region. So it might be that we look at something like a Thomas test, which I'll show you on the next slide, looking at sort of hip flexor, quad and sort of TFL or ITB tightness restrictions that are there. You could delve into that a bit more with the OBAs. And also looking at the sort of hamstring, what is going on at the back of the knee. If that is incredibly tight and everything above that knee is particularly restrictive, again, there's less give. And also thinking about that with the calf that we saw on the previous slide with the knee to wall, or you could look at the range of motion manually in a non-weight bearing position. I'd always have a little look at internal hip rotation. So again, if they are particularly stiff in that hip, what they may do is then increase the amount of trunk flexion that they have, or they may well start to compensate more so with load going through that knee. If they're getting the problem in a deeper squat position, you might have to look at that hip 90 degrees and look at the discrepancy one side compared to the other. And then the other thing that you could do is maybe look at the tibial rotation that they have that's here. So again, just thinking everything proximal, everything distal, for the sake of sort of 10-15 seconds. If something is amazingly stiff compared to the other side or limited range of motion, again, there may be compensatory strategies. So as you're going through your loading focus, you may want to address some of these with soft tissue work, self-led stretches, mobility drills, etc. Now I'm going to show you this Thomas test if you haven't seen it already, and then I'll come back and finish this off.
So if we look at the Thomas test, what we're trying to do is really work out whether or not there is some hip flexor tightness that is up here, whether there is rec fem tightness, thinking about that as a two joint muscle crossing your hip and your knee, and then also whether or not that TFL is tight in addition, which might swing them into abduction. So the way that I would do this is just take the athlete up into full hip flexion, take them all the way up. So I've got two hands free by putting their feet flat on my chest. And then what I'm doing is just almost monitoring when that sacrum makes contact with the bed. In that position there, what I'm going to do is just lower one of the limbs. I'm going to do the near one for ease and maintain the exact same angle so that is stabilized in that position. What I'm then going to do as we do that is just look and see whether or not there is any lift of the femur relative to the bed. That would indicate some hip flexor tightness. If they can get that completely straight on there, then again, we're probably looking at that as being a fairly normal level. And again, we'd look one side compared to the other. Now, if I get you to hold on to that limb for me and maintain that position, it then frees me up to then manipulate what's happening at the knee. So if the rec fem is particularly tight, what will happen if I monitor underneath this athlete's thigh, so just for, look, I've got my hand underneath here, monitoring the pressure. If I then take that knee into extension, if it's a rec fem tightness, what will happen is that will drop back down and the pressure on my finger will increase. If it goes the other way, so I might decide to do a knee flexion here, which again will add more tension onto the rec fem, not do anything up at the hip flexor region. What might happen there is actually this starts to lift up a little bit higher if that rectus femoris is tight. This position is ideal. Just again, you can go from midline straight down and look at what's happening angulation wise in terms of the swing out of the femur. That would indicate some TFL tightness, obviously the influence of that iliotibial band that comes off it. So it gives you quite a lot of information, this test, relative to what's going on. I'd always then assess the other side. So I'd maintain that same position there. I'd take the tension off here, bring this other one up. Make sure you've got that same position, monitor what's happening in terms of the touch. Swap sides, particularly if they're a footballer, like this guy is. So you can see so much more space underneath the thigh on this one compared to the other one. So if you hold on to this for me, James, hold that, and you can see you can get probably 2 or 3 fingers underneath here, which again indicates either hip flexor tightness or rec fem tightness. Again, if I straighten out the knee, what may happen is that drops back down, which it does, which is indicative of rec fem tightness rather than just the hip flexors. Or I can go the other way and bend that knee and basically look at what's happening in terms of the lift off. So if I bend it and it starts to lift up in terms of the femur, again, that's indicative of some rec fem tightness rather than the hip flexor region. Same thing again, looking at the angulation and the amount of swing off midline. You could draw an imaginary line straight down the middle of this athlete and measure the number of fingers. So again, lots of different measures that you can do so you can monitor whether or not you've made an influence from your treatments and interventions. So hopefully that gives you a good indicator. You can drop that back down again. Thank you very much.
Okay, so that is obviously looking more at a few different structures. If you literally want to check your quad tightness, just do this. So stick them in prone, make sure that they aren't extending through their lumbar spine, so they aren't dropping into more anterior tilt as you do this. And then basically just take their heel to their bum and measure the distance from their heel to the bum, one side compared to the other. Again, eyeball it. You might have individuals who are a lot more mobile naturally than others, but if there's significant difference or it potentially provokes their symptoms, it might be a work on. Now, again, sort of looking at things a little bit more functionally, you'd obviously want to have a look at people doing a squat because that is going to recruit your quads. From there, you might go double leg and then also look for little compensatory strategies. So are they loading more through one side? If they are, just call them out for it. So basically, can they do a single leg or a split stance squat potentially? So there's more emphasis onto one side. And again, look at what they're doing. Where are they compensating from? Trunk flexions, etc. And also, what's it like maybe into sort of a deep hunker position as well. So again, are they getting any pain during that? If they are, what depth is it that they are getting that pain at? Typically, what I would normally see is that as they go through that transition from into a deep squat and then potentially out of that deeper squat position is where you'd normally find it's quite sore. You may also want to identify during a squat or potentially during some landing analysis, so it's a bit more dynamic. So you might be doing some double leg or single leg landing, so single leg hop things that you have here. And again, look at different angles and different planes of motion in terms of compensatory strategies. So things I would certainly look at is how far is that knee coming forward? Are they confident with that knee going forward, or are they landing very stiffly? Again, in the literature, it's found that there is a stiffness that we'll talk about and show you later on in patella tendon individuals. So they land on a stiffer knee, which again reverberates a lot of the pressure elsewhere. So that can be a factor. Again, is that trunk leaning either laterally in an ipsilateral trunk lean kind of fashion on the right hand side, or are they actually going into more trunk flexion? Again, indicative and shown with a lot of individuals who have less confidence in that knee. It's also associated that with a lack of hip extensor strength. So again, people with less knee extensor strength are going to potentially be more vulnerable to trunk flexion lean. And again, it might be that you look at people jumping down from a certain height. So again, what they may indicate is that they almost land into what would look like they were doing like an incline squat position. So they almost land onto that mid or forefoot really, and their heel doesn't come into the ground. So that might be a predisposing factor for more load going through that tendon, or potentially a compensatory strategy because they aren't as confident with their strength-based levels that are around there. So again, you might want to look double leg, might want to have a little look single leg and see what's happening, or do they land on their toes and do they compensate with a trunk lean? Now, if they're getting pain with that already, I would probably do a fairly limited plyometric assessment. However, if you are exploring a little bit further, what you might do is just look at what they're like doing some double leg jumps, almost like they're skipping, and then look at them in various planes of motion, so going forwards, backwards, and side to side. And again, have a look at what they're doing when they do it. Are they landing stiffly? Is that a very Achilles or calf dominant loading strategy, as in they're not bending their knee very much? Or are they really happy with that knee coming forward and recruiting through that quadricep region? They're little clues that you might find more so highlighted in a single leg environment, really, where there's obviously considerably more load. Now, you've got to be careful with these because you don't want this person to go out in all kinds of pain. So again, build this up accordingly. Look at what you need to. If they're absolutely fine and you're delving to explore this a little bit more and look for compensatory strategies, absolutely fine. But yeah, if they're starting to get pretty sore with this, then do have a little think about that. Bisling et al. Was the reference for you where he really sort of highlights a stiff landing position. So the knee is much more vertical. There's less give in it. And basically there's just a bit more thud going through that whole region. Now, this is something that you might want to look at in addition. This box is far too high for where I would start, but you might want to start with a little step. If you want to break down whether it is the force generation or the force absorption side, what you might want to do is do some box jumps. So as you see here, if she jumps onto there is a lot of force generation coming from that region, but not a great deal of absorption. There's reduced absorption demand. The other way around, as she lands, obviously there's a lot more absorption than there is generation. And again, you could do that in a single leg position. Now, it might be that if they are able, and that doesn't provoke anything, and you're wondering whether it is that sort of transfer of energy, so that force generation into absorption into generation again, so almost that sort of stretch shortening cycle that you get there, something like this you could try. So they're landing and going straight back into a jump. So they're landing, and coming up. So that ability for that tendon to load and then regenerate is obviously something that we would want to try and restore in rehab. But if you're really looking and searching or wanting to know where you sort of put more of your little poker chips in your, when you're divvying up where you're going to allocate types of treatment and rehab, that might be dead useful. Now, there are other elements, certainly within the literature, that have come out as reasons for issues occurring or predisposing issues that have maybe left them more vulnerable. Or actually, do these athletes naturally have these problems already, or has the patella tendinopathy then led to them? It's always tricky in there. But if we think about the hip extensor, so particularly the glute max, what is that strength of that glute max like? Can they achieve enough hip extension range of motion to get the benefits of that glute max? If they hardly have any hip extension, then they have to recruit from somewhere else, which is going to add more load onto that knee. It might be the patterning as well. So again, is the hamstring very dominant compared to the glute max? Again, these are things to have a little look at. Are they achieving full knee extension? So what's the range of motion like? That quad, we can't have really gone on about it more. The strength and that ability for the absorption, as well as that generation, we need to be specific when we're rehabbing these, and again, the sort of patterning that comes with that. The foot posture and ankle range of motion that we have, so ability for that foot to land, control some pronation. Are they forefoot runners, rear foot runners? What's their stride length like, etc.? We'll delve into all of this in the second half. And again, the other massive part, it was never ever going to get left out. If there's any chance for me to put this in, your soleus strength as your sort of probably one of your, along with your quads, your next biggest absorber of force in your lower limb, your soleus. So again, we need to go really high and make sure we specifically load up that soleus. Brilliant. So that's it. We've got to the end of the sort of assessment side of things to do with the patella tendon. We've gone through, just in sort of to reiterate really, the functional anatomy. So we've looked at the sort of the load related components. So all of Tim Gabbett's work, that acute to chronic ratio, training the donut rather than sort of treating it, the subjective clues and delving deeper into what they've been doing training wise in a gym, maybe outside of the club. If you're in that environment, what's happened that's caused it to flare. Objectively, again, sort of we're looking at palpation being a pretty stonewall finger on that inferior pole of your patella. But again, it may well be coexisting with some other issues. So although the patella tendon and a tendinitis has moved from an inflammatory based idea, certainly there may be some benefits of taking anti-inflammatories, etc., if there are coexisting pathologies, or even potentially if that tendon is flared. But we'll not get into that now. You may want to be doing a look at the sort of plyometric control and output that's there. And again, start local. What's the patella mobility like? What's the quad and calf tightness strength like that's in there as well? And then again, what bearing is the foot and ankle, hip and lumbar pelvic control having?
Okay, guys, so there is the assessment bit done. I hope there's a few good little take homes that you guys can kind of dip into there and then potentially use. My apologies for the Zoom setup, I think, is behind the scenes, must be having a nightmare. So every time I try and click on chat to talk to you all, it just crashes. So if anyone's got any questions, you might just have to pop your microphone on and just ask away, and I'll try my very best to answer. If there aren't many questions, then we'll just dive into the rehab and treatment components. Anyone got anything that you want to ask at all at this stage? I'll give you a few seconds to dive in if you wish. No? Well, hopefully in the second half, there'll be quite a lot of kind of answers in terms of how to apply this theoretical side of things and then kind of putting it into practice, because I do think when you have finished this, hopefully what you'll go away with is stuff that you can just immediately start to use in your sort of clinical practice, really. So there are nice examples of the athletes going through some of their rehabilitation and some of the ways that we've managed this really successfully in the past. It doesn't look like there's any questions. Just got a little message through saying that everyone's all good. So if for any reason this stops working your end, guys, just because the chat functions, as I say, as soon as I click on it to kind of have a look, it just crashes the whole of Zoom. So if there are any issues, then please just get in touch with me. Obviously, the first bit hopefully went all right. So enjoy the second bit, folks, and I'll see you.
Hi, everyone. I'm Steve Miller, and over the next hour, I'm going to take you through the environment and beyond, really. We will hopefully appreciate and actually use little analogies is really important, because some of the words that you use can really help with that sort of top-down approach, that biopsychosocial side, whereas actually if they are incredibly stressed, anxious, kinesiophobic around this kind of thing, again, the role that you can have in explaining what's going on and putting a plan together is incredibly important. So rephrasing that we'll talk about. And it might be actually that there is this sort of elephant in the room, really, where they are frustrated. They've been to see physiotherapists before. They've seen sports therapists before. They haven't addressed the problem. They've broken down again with the same issue. And that happens a lot. Now, that's not to blame the therapist all the time, but actually some of the things that we'll go through will hopefully prevent some of those problems reoccurring. And that might have encompassed around sort of a stretching, massage, passive approach. We're going to go down the other way. We're going to go down a very athlete-led loading protocol where we try to expose the tendon to the load that it requires to then make the changes that we need to in order to give that sort of tendon stiffness, stability, strength, and control. The timescales are also something really important to think about. So how long do you think it's going to take you to get back to the level that you were at before? Ask your individuals what that is. Have a little think yourselves. What do you think that is? Again, it's going to depend on the stage of the tendinopathy. So again, you should have watched the first part of this, hopefully, so you've got a better understanding of that. But again, how you're going to build that athlete up to get them back in again, and being mindful of the time that's involved with that. Again, that could be sort of 3 months plus, but it might be you get them back in before then. But actually in the background, that tendon adaptation is still occurring, and you're still doing all the things that you need to in order to promote that improved tendon health, if you like. Again, we are going to try to modify more than rest. So again, most people will be on that carousel of sadness that we talked about in the first part, where they have rested, they've deconditioned, they've actually got weaker, some things may have got stiffer, they've become less exposed to load, so they become less specific to what the activity that they're going to go back into, and then they go back in again after a period of rest, be it weeks or months, and then they just eventually sort of break down again after a few days or weeks after that, really. And the usual reason for that is, again, that we need to address sort of the reason behind why it's occurred. So the frequency, the duration, the intensity, or has there been some sort of plyometric input, or a little combination of all of these things that you need to think about when you're managing this. So again, that sort of top-down approach, communicate that with the athlete is really, really important. Communicate it with the coaches, communicate it with the rest of the medical team, the S&C staff, the rehab team, whoever's involved in that journey, so they're all on the same page in regard to what's happening, the potential risks of going back again, the risk of secondary injuries, etc., if you need to. And what you want to do is obviously get an athlete back in again without that sort of breakdown and problems that they're going to have beforehand. So be very patient-centered and go from there. Now, again, the way that you frame this can be incredibly important. So what can they do rather than what they can't do? So when it comes to loading, they've probably been told, you know what, jumping's bad for you, landing is bad for you, running is bad for you, doing anything that is potentially explosive is bad for that patella tendinopathy. But actually reframe that and try and put it into a context of actually what can they do? So you're reinforcing positive messages all the time. It might be that they can't do a great deal at the moment, but actually in the current state that tendon is in, this is what you can do. you might need to reframe it in the sense of that someone may have told them following an ultrasound scan that they've got a hole in their tendon, thinking about the ground substance that's there, that non-contractile substance that is in there rather than that nice collagen that there should be. Again, they may have a preconceived idea as to what that looks like. It may be something that is potentially vulnerable to getting significantly worse. It doesn't sound great having a hole in your tendon. It doesn't sound great having neural ingrowth into your tendon. It doesn't sound great having blood starting to flow in there, which isn't there already. And they may have seen that on an ultrasound and freaking out. So again, try to educate on that. So it's very much a modification side of things rather than a stop approach. And again, we'll go through quite a lot of the ways that we can control the load, even in the early stages, and then gradually build them back up again when they're ready. Rest, as ever, with any of the work that you will have seen on this, is active rest. And then we're looking at short-term, medium-term, and then sort of longer-term strategies, really management-wise. Again, when they come to you, this tendon may be a bit lit up, so you might need to do some things to just take the sting out of it. Let it calm back down again before we start to build it. So that sort of sin factor that you have a look at will again sort of determine what you are looking at. You'll be able to term it in terms of, is it reactive, is it disrepair, is it degenerative, or is it maybe sort of a little element of a lot of those on top of deconditioning and other factors that are potentially sort of contributing in there. And the other thing that's probably worth addressing, I always find, is actually that discomfort is absolutely normal and actually it should be encouraged. So again, in the literature, when we rehabilitate the tendon, if they have pain that's less than sort of 6 out of 10, so anything from 1 to 5, some individuals may well be very reluctant to push on with that. But actually, you can reinforce the literature actually encourages you to have some sort of reaction in that tendon in order to make a change within there. You are loading it, you are stimulating the fibers that are around there. There are pain sensitive structures that are there. Again, how that reacts afterwards is again really important. Immediately after they've stopped the exercise, and then that sort of 24-hour period after, or how it feels the following morning. Because normally they will have been on this, and again, just to reiterate, that tendon carousel of sadness that they are often on, you will have flares, they will then rest. That pain will settle, they'll deload it, they'll become deconditioned. If they've seen someone before or they've tried to massage it, Theragun it, etc., again, they're just going to be in this cycle where that then just starts to decondition, whereas that tendon loves load, doesn't it? We want to try and expose that tendon to load. Otherwise, when we drip them back into training, we spike that load, we go above the capacity of that tendon, and then we break down again. And that's why the psychology of a lot of these individuals is incredibly common. So we find that they're amazingly frustrated because they just can't perform at the level. It doesn't last very long. It's taking longer and longer for it to warm up in a training session, etc. So again, they may come to you and say, you know what, Steve, I've already tried isometrics. They don't work. My question is always sort of, were they heavy enough? How long did you hold them for? Were they specific enough to what you wanted to do? What ranges did you look at? And we'll talk about, again, making sure that we don't go beyond sort of 60 degrees with some of these isometric holds, just because of the impact on that patellofemoral joint can actually flare things. And again, if they're doing it in that end range extension with the relationship and very close proximity to that sort of infrapatellar fat pad with that tendon, again, they may well have irritation of surrounding structures. So it's not just the tendon that's a problem. So there may be concurrent things that are going on. The other thing I'll ask is, were you progressed when you were ready to? So did that individual, or did you, when you went back, did you go through any sort of form of battery of testing to make sure that you were ready to go back into whatever it was you were going back into, running, maybe some light impact work, maybe jumping, plyometric work, gym classes? What did you do to make sure that you were ready? So was there enough capacity before you started dripping in some of those variables that we get? The answer is very often no. The other things that I always ask about is, did they look sort of wider? Did you just literally go narrow lens and look at that tendon, just load that? But actually, there's other factors that may well be going on that are contributing to that. It might be that something that is training related. So it might be you have to obviously get the coaches and the S&C staff on board to look at how much load they are spending on feet. And what is it maybe in a gym environment? What is it within the sport? or positional demands, the components of plyometrics, jumping, etc., that actually they carried on going with, and actually that carried on sort of almost poking the bear. Intrinsic tendon qualities, again, you might need to educate this individual that they have changes in that tendon. They may have elements of ground substance that's there, but again, we're going to train everything around that to make sure that we get enough strength and support through the tendon, and we increase the cross-sectional area without that sort of pathological thickening that we talked about in the first part. And again, the other thing I will always address is that timescales factor. And then the other thing is they may have dripped back in again looking pretty good, but actually what did they do after they went back in again? Did they then stop doing all of the extras that they were supposed to, that they were advised to do? And therefore things just sort of regressed and then became a little bit more vulnerable. Did they start to avoid using that side? Were they still doing single leg work, etc.? Were they still carrying on with their isometrics? And again, the severity of that tendinopathy will depend on where you start with this. I would say that the vast majority of the ones that come to us are the ones who are sort of starting to become limited with their performance. But again, if you can catch them earlier in that sort of mild phase where they're sort of self-managing it a little bit and help them the best that you can, that is obviously going to try and prevent that progressing and becoming more of a chronic or harder to deal with issue. Again, if they are really sore, that pain level's really high, sort of up in that sort of 7 or above territory, that's the sort of more severe ones, aren't they? They are obviously going to take longer to calm down. They are probably going to have adopted over time some compensatory strategies to try and avoid using that tendon. And again, what you might have to do is be a lot more box clever with breaking down the biomechanics, breaking down the way that they load, building the confidence up to create a foundation, and then starting to drip them back into what they need to. And again, the load is usually the key to that. So we talked again in the first half about trying to reframe this as a spring rather than something else, really. So again, with a spring, that will obviously hold some elastic energy within there. The tighter that is coiled, the more energy is held, and then it can spring out of there. If you are stretching it, or there is something that is impeding it, so the little interfaces, you don't normally get many compared to something like an Achilles around the patella. There is obviously the fat pad that sits pretty close, but again, there's not as many compressive tensile irritants around that knee compared to some of the other tendons, particularly sort of glute-wise, etc. So that shouldn't really be too much of an issue. The next thing, again, is just to try and identify whatever the spike in load was that caused this person to develop problems. Now, that might not be crystal clear. You might have to look at again, all the different elements of what's happened over the prior few weeks and look at the sort of acute to chronic workload ratios that we'll talk about. But again, it might be the volume. So how long have they spent on their feet? It might be the speed, and it might be that they've been going incredibly quickly. It might also be that they've been going incredibly slowly, less commonly so. That's normally a sort of Soleil-C sort of trigger. But it might be sprint meters, it might be change of direction, it might be accelerations, decelerations. So if you've got something like GPS, that is an ideal tool to use. And again, it might be the way that the training week has gone. So the structure of that may well be important. So you need to know what they're doing out there. You need to know what their demands are. They may be doing extras. They may not be. They may have areas that have been identified that are work-ons for them. So particularly with us, with second rows, they do a lot of jumping. If their line-outs weren't going well, they would be out there for a long time doing the same routine again and again on a jumping frenzy. They might be jumping for up to sort of 40 minutes at a time. Obviously not continuously. But again, they're little triggers that might well have occurred. So delve into that. And again, that history, that pattern, how they were managed, treated in the past. Is this a new problem? Is it an ongoing problem? Is it something that just intermittently keeps raising its ugly head? And again, those are the ones that you're probably thinking there are potentially either issues with the way it's been managed initially and it's never been addressed, or there may be some degenerative changes that are occurring within that area, or something biomechanical, something that's feeding into that, either the way that they move, the way they land, the way they jump, etc. And the other thing, again, you need to have their active engagement in the process. So with some things that you can manage short term and turn around in a week or whatever, some passive treatments and can help, but you definitely want to move away from that fix me sort of mentality that you sometimes have with some of these athletes. They will feel much better once they start loading through this tendon rather than getting massages and rubbing and basically poking at this tendon, which we know that tendons don't really like stretches and they don't really like being prodded or poked. And again, think when you are going through this journey, how you're going to mimic the demands of that sport when you go back in. So this is just a little example of the acute to chronic workload ratio. So you're going to work out really where they are on that scale. So you're going to look at the last 4 weeks, look at the last 7 days and just compare that. Now, it's beyond the realms of this presentation to go into it. I would certainly recommend having a look at some of Tim Gabbett's work on this area. And again, this is just sort of a little reminder on the left-hand side that, again, if they are told that there is a hole in the tendon or there are some little areas that are weaker than others, they might have this image, but try to reframe that. You want to try and get the muscle stronger. So your quads directly are going to have an impact on that patella tendon and quad tendon. If that is stronger, there will hopefully be less load specifically going through that tendon. I sometimes call it almost like a bit of a hydraulic. The stronger your quad and your soleus is when you're moving, the more sort of cushioning that you have in that area. So there's less demand through the tendon. I think it's probably worth sort of saying actually what we're trying to do is create a denser tendon rather than a thicker tendon, because that sort of pathological process that goes on where your body tries to lay down more tissue to make your tendon thicker is actually pathological. So it may be thicker to try and cope with the demands, but that's not actually a good thing. So we're trying in order to sort of find out a little bit more about increasing the load of the good bits of that tendon. And again, how do we do that? We're going to train the donut, not the hole. So anything around there, we're going to get that nice and strong, create a lovely, healthy tissue in all of the bits that we can do. And actually, we're probably not going to change the areas where there's ground substance, but there should be ample tendon, good quality tissue to cope with the demands if we manage this correctly. And often there's a bit of a lag with this, so they don't often feel the benefit straight away. And you just sort of say, look, trust the process. We've gone through this with a lot of athletes. It is an incremental loading process, exposing you bit by bit. You won't come back on a weekly basis and feel much better. This will take some time, but trust me that it will. And the way that we will do that is typically with isometrics. So the way that management of patella tendinopathies has changed over the last sort of 20 years hasn't been a great deal, to be honest. So they've generally gone on to a decline board or something that is going to put that foot in a decline position. The reason for that is because it increases the amount of quad activation on Purdom et al. Study. And again, I've just put a couple on there. So on the left-hand side is the way that I would load them because of the fact that you want to try and keep that trunk relatively vertical if you possibly can. Something like a sort of pistol position, you can also obviously go into the one next to it. There's no harm in that. It does just bring your trunk into slightly more flexion. You may want to load them to the maximum angle until that pain occurs. So if that is happening before 60 degrees, so let's say they get to 40 degrees and then they start to get pain, again, what I'd probably do is just take them a few degrees out of that so it's tolerable and then work on building up from that position. Once they get low through it, it has that nice little analgesic effect. And basically what you can start to do as time goes on is then really look at sort of some of these. So going into an eccentric controlled position, holding for a period of time that you set them, and then sort of coming out. So you've seen the way that I would ideally do it. And then obviously you've got this other version. Again, absolutely no problem with this. It's just a variation that they may well prefer. They may feel a little bit more confident with that. But again, what we're trying to do is go into that position. And if they struggle at the bottom, what they can do is just pop the other foot back and then lift up from there. Now, interestingly, why don't we just do it as a squat? Well, actually, they've done a little bit of work on this again. Craig Purdom, one of the leading guys of the big four of Jill Cook and Pete Malliaris and the rest of the gang. When we think about why we do that, he actually did an interesting study looking at people who did the same program and half of them not even half, sorry. So 9 of them that were selected were put into the squat group and 8 were put into the decline group. Now, interestingly, at the period of time that we wanted them to return, only 1 of the 9 who were in the squat group returned effectively to their sport, whereas 6 out of 8 returned to the sport. Now, I appreciate these are very low numbers, but again, if we look on the left-hand side, if someone is squatting, like the far left picture, then there's not a great deal of load, if any, really going through the quad. So this is how a lot of people will cheat. You want them to sit back, so try to keep their tibia a little bit more vertical. If you like, it doesn't have to be vertical. There is no harm really in that knee coming over the toe, other than it will add more load onto the patellofemoral region. But we can obviously just hang on our ligaments, can't we, and cheat in the far left position. So again, what we're trying to do really is gradually angle them onto a decline board. And again, some further studies from Zwerver et al. He's looked at different angles and what the best angle is. So 15 to 30 degree board is the best. And again, from just to back up, that sort of less than 60 degree angle is preferred. And that's just based purely on the fact that it increases your patellofemoral load hugely once you start to go beyond sort of 60, 70 degrees down to 90. And then obviously beyond there, it rockets from there. And eccentric rehab, there are loads of gurus, isn't there? Lots of evidence that's out there. Alfredson's program, Kongsgaard, sort of slow, heavy resistance work, and then Pete Malliaris really with a lot of the sort of rationale and looking at lots of other different sort of ways that we can start to load. And there are other things. If you don't have a decline board, you can use some of these. So utilize squat shoes that are a little bit more raised. You can just plonk some plates underneath their heels. If, again, you are trying to keep that trunk a little bit more vertical, what someone might benefit from is maybe having something like a core ball, or just sliding up and down a foam roller, or up and down a wall against in the gym somewhere, because that will encourage them to accept more load into that heel region and lean back into that. You can also just use it normally in most gyms as a step that people use for classes. Again, you can take off one of the legs on the far right-hand side, then you can see just on that decline. What I would say is when you are loading this, just try to use the same equipment and angulation each time. And again, I've gone on about this probably enough about we are trying to load it. The common thing is that they ask is, well, should I be stretching my tendon? And they've probably been doing this themselves with very little benefit. And the reason is usually because they say, well, it feels really tight. But actually, there aren't any of those sort of contractures. There's not taut bands like there is in a muscle, potentially, that you can get into and release. That's not to say that you can't work into the quad itself or the hamstring if that is particularly tight, or even the calf for that matter. Again, but what we want to try and do is reframe this completely into something like a coiled spring. So when that spring is together, it holds more stored energy, doesn't it? And then when we let go, it's able to explode and have that nice transfer of energy. If we stretch that, or we rub it, or we loosen things off around the tendon, potentially, if that's even possible, it's not, by the way, then yeah, what we're probably doing is just creating a bit of a problem where we're actually losing some of that elastic energy and storage that's there. And it is fascinating because when we start doing isometrics and reach that analgesic load, that tight sensation starts to reduce significantly. So something like this is an absolute waste of time from my perspective. So using something like a little Graston tool or something just through this quad is not going to make the differences within that tendon in the slightest. There's also very poor evidence for ultrasound, very poor evidence for some Syriax's sort of deep transverse friction massage that you get that's there. Electrical stimulation is not particularly well evidenced. Stretching, foot orthoses. They're all things that don't have a great deal of value. Now, electrical stimulation wise, if you are using something like a Compex, I actually think that is quite useful. So neuromuscular stimulation, that you would put the pads on, turn it on, and then you start to get that quad firing. You often find, if this has been a problem for a while, that quad has started to switch off. It may have lost a little bit of bulk. So actually, in a non-provocative way, you can start to get exposure to load and contraction through that quad quite nicely. In terms of non-steroidal anti-inflammatories, or orally or potentially topical gels like your ibuprofen gels, Voltarols, which has diclofenac in, some of those, as long as you don't start really aggressively rubbing them in, I don't have any harm at all in taking them. It's been a little bit of a contentious area, whether it is a tendinitis, then it moved to a tendinopathy. What's a tendinosis? Again, and anything with an itis on is basically just an inflammation. And then they found that the tendon doesn't inflame, but actually around there's plenty of other structures that do create little chemicals if they're irritated. So there may be elements of inflammation there. So if I'm honest, I often put a lot of my athletes, if they are really sore and can't load, onto anti-inflammatories, or ask them to just pop some Voltarol gel onto that region. Just don't rub it in aggressively. Just literally just stroke it on, let it absorb, and go from there. And again, that's sort of backed up by Corks et al. In 2014. So we're avoiding any direct pressure onto the tendon because it doesn't like compression. We certainly aren't going to go deep sort of transverse friction on it. The only time I think I've ever done that with any success is in a really chronic hamstring, proximal hamstring tendinopathy, that nothing else worked. So it was out of pure desperation. They'd had PRP, they'd had pretty much everything loading wise, but was still sore. And it was like, this is the last throw of the dice, is the only time that I've ever used that, and it's had any benefit at all. Again, you might want to go in and do some quad TFL, ITB release style work. That is backed up by this study. Not even going to try and pronounce his name. But again, it's going to potentially reduce the tug and traction onto there. Because if we think of it almost as an enthesis, where that tendon attaches onto the inferior pole, then again, there may be elements of reducing the amount of tug onto there will certainly help. And again, sort of biomechanically, if that hamstring is tight as a drum, they can't really extend that knee particularly well. So they may be landing on a slightly flexed knee, or landing in a slightly different way, particularly onto the forefoot, will add a heck of a lot of load onto that patella tendon. I would say have a little look at that, not just in a straight leg raise way, but because we're looking more at that distal end, pop the hip up at 90 and then start to extend the knee from there. So we're getting more of a knee bias to it. You might want to have a little look at the lumbar and hip region. Hip extension and medial hip mobility are things I typically find are not very good. So you might want to have a little look at those. So again, something like a sort of Thomas or Ober's test might well give you a little bit of an indicator as to the tension that's in that sort of quad, and then also thinking about the amount of hip extension they have before they go into anterior tilt at that, or extension at that lumbar pelvic region. And then what we're going to do really is just, again, once we've created range, or if they are weak in that range, then again, what we want to do is try and get more of that glute max activation, so the drive comes off that when we're trying to propel ourselves forward. And again, other little things that you could do to improve the amount of hip extension. You can see the various sort of pictures that are here. This is a little bit of an example of some sort of introductory 3D stretching that you have here. I would just be a little bit cautious with this, particularly with the irritated tendon that is there. You may not be able to tolerate that position because of the pressure onto that region. So you might need to put something pretty soft underneath to avoid it, and also just be a little bit careful with how high you take that back foot. So if you are putting it up onto something, it is naturally going to put the quads on more stretch, and then again, you're going to work through this process, but it might be one that actually starts to irritate it. I prefer some of these dynamic positions compared to the static holds on that quad, because I think it just tugs on the tendon and makes it pretty sore. And then on the right hand side there, again, you can just see another couple of ways. I like the standing one, basically that sort of classic old school calf stretch position, but starting to pop that pelvis into some posterior tilt and then bring yourself forward onto that front side. Now, while they are particularly down in terms of the load that they have, this is a prime opportunity to work on things around it. Now, again, your quad and your soleus are probably your two biggest force absorbers in the lower limb. So this will cause no irritation whatsoever to your patella tendon region. So loading up with the soleus on here with that knee bent, Again, we don't have to worry too much because there's not much load going through this, so there's very little demand on that tendon. And then again, what we have there is the blood flow restriction cuffs, again, just to accelerate the amount of DOMS and sort of muscle cross-sectional area and strength, hopefully, in that region. Now, most people won't have blood flow restriction cuffs available. There's no harm in that. Just pop dumbbells on or have a little look around at various other things that you can find in the gym. I use this all the time. So this is the hamstring curl machine. Again, just sit on a little box next to it. Try, if you can, to work through full range and also have a little look one side compared to the other. So again, prime opportunities to do little strength-based testing. This won't put any real stress through the patella tendon. So see what their load exposure is like. Just remember, you've probably got up to about 6 times body weight going through each soleus as you run. So again, just doing this as a body weight sort of level is not enough. But yeah, here we are. So this is where we'll probably start. So we've talked about isometrics. I'm going to show you how we go through that process now. Then we'll go through, once they are ready, into an isotonic phase. So again, you might have isometrics still running alongside this, and then really going into that sort of energy storage and release, where we start to do sort of the plyometric related work. And then what we're starting to do is drip them back into sport and look at the criteria that's demanded there. So again, we're thinking about the amount of load that is going through the patella tendon during the certain activities, how many rep sets, etc., how frequently we do it. Again, there is a huge emphasis now on and satisfaction on trying to do heavy, slow resistance work because they don't have to do anywhere near the volume and they don't have to do it as often as something like an old school Alfredson program that was sort of 3 lots of 15 twice a day. You don't have any time for anything else in your day to do. So again, I've talked a little bit about analgesic load. So what does that actually mean? Well, it basically acts as a way to reduce the amount of pain that they have within that tendon by loading it. Now, there's often a bit of a fear initially with this. So you do have to explain how you're going to do it, and you're probably not going to start at, or you certainly won't be starting at 70% of their max voluntary contraction of sort of a 1 rep max. And then what you're trying to do really is find the modulating amount. So normally 60 to 70% is where you'll aim. And then therefore what you do is start to build up the duration that they can hold that for. Now, again, you're going to think about a few things with this. So if you have pain above a 5, then you're really overloading that tendon a little bit too much, certainly in the early phases. You might be trying to keep it around that sort of 3 to 5 territory. Certainly not worried at all about something that's a 1 or a 2 out of 10 at all. Again, reiterate it, that's totally normal. We're pretty happy with that. That's your baseline probably anyway. So actually, what we're more interested in is what it reacts like afterwards, or if it is going above that, then maybe we have to change the duration, maybe we have to play with the load, maybe we have to change the angulation of that knee. But again, what if you can get them to do prolonged holds, and the ideal is 5 lots of 45 seconds, eventually once they get there, what you will find is actually that the pain that they have, or the amount of time it takes for that tendon to warm up, is far less. So again, we can start to drip this into their programs. If they're not particularly irritable, they might just find that this on its own is enough to keep that tendon ticking along and they stay within sort of full training. Normally what we do is just adjust that slightly, take them out of the high intensity, maybe look at reducing the amount of accelerations that they're doing, the amount of sprint meters, etc., which put more demand onto there. And what's happening with that isometric? Well, it does lead to an upregulation of insulin-like growth factors and cellular proliferation and matrix remodeling. So they have been shown within that. And again, all we need to think about really is it the tendon that's sore, or is it some of the other structures, thinking about that fat pad? So this might be things that you start to do really. So it might be you just start with an athlete who is in sitting, they're pushing into a core ball at the load that they are happy with. Again, the further that her bum would be away from there, the less angle there would be. So if they were more at sort of 60 degrees, again, that might be more tolerable. So you're going to play around a little bit that way. The next one here, again, she's standing inside a squat rack. So she's holding onto a hex bar. And what she's doing is gone single leg with a bent knee. And then what she's doing is basically extending that knee. So she's activating that quad, which you can see a little bit better here, into that position. She starts bent knee. And then what she's doing is trying to drive herself up from that region. Now, again, that's probably the end of range. So that's more your sort of 10 degrees. But again, if you put that lower, then she might find that a little bit more comfy. And then other things that you often do, you could push into a wall or push into a core ball. I quite like pushing into the core ball for a bit of proprioception. You can also get them to push through the toe to get that soleus firing up in this position, so you get the co-contraction of quads, hamstrings, and soleus all firing at the same time. And again, they like this because they're in full control of how much load they're putting through that patella tendon. Other things and other ways that you can load isometrically, you can see here on a incline leg press. Again, you can alter the angulations of that foot. So imagining that that is on a clock face, so something like 12 o'clock is straight up. You might want to change the angles. The higher that heel is, the less potential load through the front of the knee there is. So that might be a little bit more comfy. You could just use something like a band, or just literally hold dumbbells by your side in a sort of split stance position. And again, you might want to add something like a band just to add a little bit of extra downward force from there. They often really like that position as well, particularly in a Smith press where they can hold on to something. And then you've also got that leg curl machine that's there as well. So again, you could find an angle that they're pretty happy with holding, and then again, tailor the weight based on what's happening. Now, if you want to start to move into stuff that's a little bit more sort of very early stage isotonic work, open chain stuff is prime for that. So again, what you can do is just get them to do a classic inner range quad exercise with something like a foam roller underneath. You might want to add a little squeeze if you potentially want to get a bit more VMO fire in there. You can do that in sitting with the same sort of thing, with a little yoga block in between their knees, just squeezing from there. And again, that just enables them to go through full range. There's very little load going through this, so we don't mind her going back down to 90 degrees at all with this. It's more when there's a sort of body weight involved as well. And then again, what we can use are sort of almost focusing a little bit more on the eccentric side of things, is going double leg out. So they've got the good or the less injured or the non-injured side working, and then just progress it. So find the point that they're happy to load to. Again, some of Claire Robertson's work, really from 90 to 45 degrees in this position, there's actually significantly less load going through the patellofemoral region. So it's kind of a little bit of the opposite if they are in a closed chain body weight position, really. And again, there's lots of other things that you can do. Again, sort of in an isometric position, you could do bridging work. Again, making sure that they don't lose that contraction of quads, hamstrings, soleus. They've just got a band on there just to, again, engage a little bit of glute. And they can use things as well, like their upper limbs, to support them if they still don't feel very confident. So this guy, using the TRX, pulling himself back up from that sort of mini squat position. Again, he could just be doing that as an isometric hold at the bottom, really slowing down what he's doing, but he feels happier because he's got his upper limbs that he can use to help him back up again. And again, sort of things you will have seen in other modules, I'm sure, but looking at how we activate the quad and the VMO using things like a band just to pull back against. And again, we're going towards that terminal extension position. So again, that control that we have there is really important for so many activities. And again, they're usually pretty comfortable in that region. Now, she is going lower for a patella tendon than I would go. So I would stop her at about 60 degrees-ish again, or at the point where she starts to get that maximal amount of pain. So we're not looking to generate, again, more than sort of 5 out of 10 pain really when we do this. Other little cues, again, some people like to have their knee in contact with something, so they often feel a little bit more confident. So something like compressing into a Swiss ball is nice. Again, you can do that as a prolonged hold. Chuck in a band so you get a little bit of the best of both worlds. And then again, what you can use are something like this. Again, these are good little quad burners, that sort of banded downward dog position that she's in, letting those knees bend and then extending back over. And again, thinking about the angulations is all good, and then it might be that you almost break that down and get them to work on one side, then the other, or just work on the affected side. Again, slow them right down. Eccentric stuff needs to be slow, it needs to be controlled. And again, this just sort of touches on that acceptability or monitoring model that we have, really. So if the pain is around that 0 to 3 kind of level, we're fairly happy with that. Actually, we expect it, and actually we encourage it. If it is getting to 4 or 5 out of 10, again, if that's during an activity, again, we're not fussed as long as it drops back down again after they've finished, or in particular the following day. Because if it is staying at that 4 or 5 out of 10, that's probably a little bit too much load at baseline from what we like. I would usually say if someone has a baseline ache of, say, a 1 or a 2 out of 10, I'd be pretty happy with it going up to a 2 or a 3 out of 10 after they have loaded it. That's absolutely fine. So I give myself a little 1, potentially even a 2 leeway with that. And again, if things have been really stirred up and that pain is getting up to sort of a 6 to 10 or 10 out of 10, that is the area where really it's a little bit of a reminder that it's not very happy. It's probably going to be a little bit sore on compression or palpation. And actually what we need to do is actually regress things a little bit in order to build that back up again. If you plow on with these and you don't let that calm down again, it often ends in tears. And again, these are other ways that I would potentially use during rehabilitation. So I would have that subjective score. And again, if I possibly can, I will use an objective marker based on what is happening with that tendon. So I would get them to do a 1 rep static hold in a consistent setup. So again, we talked about my ideal position. That might not be available to you. So again, whatever you decide to use, what I want you to do is assess the amount of pain that they have during that exercise. So they may be doing a 15 to 20 second hold at a certain angle, or you set the angle and count how long they can hold it for, or you look at the amount of pain that they have while they are holding that during that 15 to 20 second hold. Again, the same sort of thing, as we said before, backed up by Kongsgaard in regard to we're looking at really sort of 3 to 5 being a pretty acceptable level of pain. So if you have someone who's a little bit fearful, reiterating this is super important. And again, Pete Maliaris and his cohort backing up again, most important thing for them is that 24 hours post-training, what do they feel like? And again, what you're likely to do with the heavy loading is you're not going to do that consecutive days as things start to get heavier. So again, the following day, you can get a good gauge as to where they are. Fab. So then what we want to do really is try to build in some isotonic work. So again, the focus is more on the eccentric side of things rather than the concentric to start with, because that's where there's more evidence. That's when we get more tendon change. So as you can see this athlete doing here, he's going 2 feet up and then actually he's just bringing it back with 1 limb. So the concentric phase is helped by the healthy side, whereas the on the sort of single one, he's bringing it down on that affected side. And it might be, he's just showing you here for comparison, doing one then the other. Obviously, if you want to start to look at really doing 3 to 4 sets of 12 to 15 repetitions would be where I would start off in the sort of early phases. So we're more volume focused. And in those times, really, you're looking at sort of 2 days on, 1 day off, because there's not much load going through it because it's still quite low. Whereas actually as things get a lot heavier and we start to move towards that sort of 6 rep max level, really we're starting to get some pretty heavy DOMs, some pretty good loading that's going and exposure through that tendon. And these are some of the other things that you can do. Again, thinking about different ways to load it. And as we did on the decline leg press before, on this hack squat is again where I spend a lot of my time with the athletes. Put something underneath their heel, again, so they're in that decline position. And again, what we're starting to do is look at just different angles that you start to put that at. Why do we do that? Well, it starts to expose the tendon to different things. It also keeps the athlete a little bit more engaged in what's going on. Then what we might start to do is just load them. And you can see sort of on the way down, he's got a band attached onto that there. So it's actually helping him in the sort of concentric phase, if you like. And again, this is a little bit lower than I would go to unless they weren't having symptoms. But we're starting to build up quite nicely from a double leg into a split stance and then up into sort of a single leg squat position on that hack squat machine. Again, on the sort of the right hand side there, this is them going through what I would go through with a lot of our athletes is 5 separate points. So imagine in a clock face, starting at 10 o'clock, then going to 11, then to 12, then to 1, and then to 2 that he's at now, really. And again, the amount of time that he holds that for, ideally as long as possible. I would start off as a minimum at 5 seconds per position, and then what I'm really starting to do is trying best I can to get that up to sort of 12 seconds per position. So we're then looking at about a minute for a hold, ideally. So again, what are the sort of research elements and the trials that have gone on talk about when it comes to exercise dosage? Well, again, the bias towards heavy, slow resistance is clear from Maliaris and the gang again. And then thinking about sort of looking at the comparison of just body weight on a decline board. So it's very apparent here that actually once we start to load it, we don't have to do as much. And actually we start to get change. It's all to do with the exposure on the load. It also has a massive bearing, you can see on there, people who just did body weight decline squats, their satisfaction levels 22% compared to 70% on that heavy slow resistance work. Whether or not that is just because it was done every other day versus every day, I'm not sure. I think they were probably happier because they actually started to get that analgesic effect. The tendon started to feel better, and therefore they're reporting a much higher level of satisfaction. You can also do some of these. I quite like these. So you've almost got one side doing the isometric work and then the other side doing a little rollout. So again, you've got that nice isometric position, which you can drop in a band. Again, if they look like they are starting to corkscrew or lose control, or they're not getting enough sort of alignment, you can use that as a little bit of a gauge. And then again, sort of getting them to load in a positive sort of fashion. Again, you might want to just use a decline board, which I would do. But again, these are quite nice to start to build a bit of confidence, taking them away from something like a TRX machine, or needing some extra stability and support there. So eventually what we start to do really is start to get them to load best that we possibly can. So I've just shown you that's the sort of angle that we want to get to. And again, what she's going to do is start to load that quite nicely into that position. Again, she doesn't feel the pain until she gets to what's probably there 80, 90 degrees. So we don't mind as much her getting down there. But if she was feeling that higher in that sort of position, again, with load, I'd probably prefer to load her there because it's more functional. It's not very often that we need to go into those deep squat positions. But then again, sort of depending on the sport, the position and the individual that you have, again, it's going to vary. So as we had beforehand, what you might want to do is almost set a little marker of something that they want to go down to. So again, you can just create something for them to drop to that position. So she feels the bag on that step, and then she knows that that's the level that she wants to get to. Again, she can take that bag away if she wants to and go a little bit deeper. And these are just, again, sort of if they're still not very confident or different options for you, really, you've got these. So you've got your TRX, you've got your Swiss ball rolls against the wall, which again, you can sort of add load into. The TRX, again, great option if you want to sort of progress from a double leg into a single leg if their stability isn't very good. Again, the major focus here is trying to build the load onto that side. And again, if you want to limit the depth that they're going to, what they can do is drop down into this sort of position. Now, if they are still not very confident on the concentric side, you can do this. So just stick them next to a lat pull machine. That will help with the concentric phase. And it means that you can really focus in on a really slow eccentric phase with the confidence that that's going to help them back up again. So again, I just want to sort of talk about this, really, this tendon neuroplastic training that's out there. Again, there's a massive amount of satisfaction with the isometric loading that we have. Clearly, we're going to get hypertrophy benefits through the muscle, but also that tendon exposure. So it's a double whammy, really, if we're struggling with anything isotonic-wise. Think about the sort of timing of that stretch, shortening cycle. From an isometric position, you might choose to do different isometric angles and then build that in. And that's usually quite nice as a transition. And you might want to use, when you start to build this in, something like a metronome. So I've just got an app with a metronome function on, and it just gives the athlete a sort of audible cue, really, in order to make sure that they don't go too quick. The temptation with all of this stuff is they rattle through it, but we know that the slower they do it, the more load that they have, the more control that they have, the better they will be at this. Now, because of that, they often end up living in a world of sort of DOMS pain, really. So they start to find that this is the first time that they've actually started to recruit through that region for a long time. So that quad, absolutely on fire. And it's then you can start to go into that sort of energy storage and release work, really. So what we need to make sure before we do this, before we start introducing anything that's more potential risk, is make sure that they have adequate strength, not just double leg because they can cheat and hide that weaker side, but expose that single leg. So I would just look at glutes, quads, hamstrings and calves. And I'd look at the output in terms of the torque, their control, their endurance, the depth that they can go to, and the bulk. And then again, what that reaction through that tendon is as they go through this. What's that like compared to the contralateral side is a bit of a guess. And what's that like to the normal levels that we should have that you find in literature. If there are any asymmetries, again, hopefully they have been addressed. So that hip extension has been restored, the medial rotation's back, any knee extension range that was lacking or lags have been improved, and any sort of, again, ankle dorsiflexion restrictions is probably going to cause that individual to land in a less dorsiflexed position. So they are going to potentially land more onto the forefoot, which again can be a massive issue. So although this is termed sort of jumper's knee, it can also be called sort of lander's knee in the, if that is constantly the problem of what's caused it. And again, what we're going to do is go through that progressive exposure, look at the intensity, the duration, the velocity that's there, and how they transfer that load. And again, think about the pain levels and what's acceptable, and is that going back to that level again. So as we do this, really, we've got the Smith press is where I like to load a lot of the individuals. Again, you can load up quite nicely. Their technique is usually pretty good. And again, what you can start to do is look at the technique. They're often a bit happier going a little bit lower if that's what you want to do. But again, with this, it's really handy because you can pop something behind them for them to drop back onto. So again, if you want to limit the range, and if they are a little bit apprehensive about going heavier, again, they can do this. And then again, they can make sure that they're 50-50 in terms of the weight distribution that they have. And again, you can do other things such as hex bar loading, which again, as she comes off the ground, she's down to about 80 degrees. Whereas what can happen, certainly, if you want to limit that range, is you can put those weights onto little blocks that are there, so they just don't load quite as low. Other things I use all the time are the landmine press. So these are really nice little options. Again, if I've got a patella tendinopathy, I'm starting to get that forward propulsion as well as that vertical output. And again, I'm putting them onto a decline board for that. And then all I'm doing really is just starting to progress that on into a split stance position and look at how they start to load. So we're starting to get a little bit more anterior translation of that knee at the same time. Now, I will always measure, if I possibly can, the isometric force going through each of those quads. So we're looking at a maximal isometric output before we start doing anything impact that we'd maybe go through with sort of introduction to run work, actual jogging work, or anything that's going to potentially cause that stretch shortening cycle to be under a little bit more tension. So this is what I do. I just load up a bar as heavy as I can, far heavier than that athlete can actually lift, put them in a slight bent knee position, and then get them to try and push up into that region. Now, again, what that does, if you have a force plate underneath and you do that single leg, is all the pressure goes down into the force plate. So you get a nice reading to look at what the output is one side to the other. If you don't have a force plate, you can use something like a handheld dynamometer, like the Microfet in the bottom right hand corner, and do it manually with yourself, or strap it into a little belt against something that is static, or some of these sort of force frames and things potentially do that as well. So then what we do is we start to increase the amount of force absorption going through there. So again, just dropping onto her toes and then landing and trying to control it is a really nice early starter for people to start to build that load. So again, what they're starting to do is go from a double leg position into a split stance and then potentially going into single leg positions. But if you see on the right hand side here, she's got a resistance band that is pulling her downwards. So the amount of load and absorption pressure that she's required with that is higher. And then she has to come out of that position. You'll see in a second when she does this, what she's doing here is doing that a lot quicker. So she's holding onto the bar and then just dropping into a split stance position much quicker. So she's starting to build that confidence, that loading, and going from there. Now, again, most people who I manage tend to be running athletes, bar the sort of British judo lot. So what we have to do is make sure that we get that exposure to some of that plyometric force. So you can see some of this here, where she's using a step just to reduce the absorption required, and then she's just driving off that. So thinking all the way between the force absorption and the force generation that's occurring here, and also the speed at which she's performing. So those little toe taps that she has in one plane, and then looking at it in a different plane that you can see here. So again, there's not as much load going through the middle foot that is on the step as there would be if she was just jumping up and down from there. So it's taking a little bit of the load out. So it really helps build confidence, exposure, and they can build in this way. This is just examples of some of the athletes that I worked with going through stuff that was similar. So little plyometric drills where they're just doing little variations, either sort of little step ups, little toe taps, and then looking at different directions. For these guys, they were doing little 20 seconds off, 20 seconds on, or potentially as it got to more higher intensity, doing 20 seconds on and then sort of 40-second rests so they could recover. Another things that are brilliant, to be honest, for exposing that patella tendon to load are skipping. So again, little variations that you can see here, different planes of motion. Boxers are always the classic ones at this, aren't they, where they can do this all day. But actually what we start to do is build from a double leg, again, into sort of little single leg variations, and just start to build that exposure up bit by bit. You can do that just on the spot if they aren't able to skip. So if they are just doing double leg, you can then just progress onto single leg. And again, what we're looking at is the control. What's happening at that knee that we talked about in the first one? Are they landing with a really stiff knee, or are they able to let that knee come forward? Or is it all the Achilles that is working that's there? So that's probably going to then lead to other issues that are there as well. So there you go. Little variations dropping around from there. Other things you can do are things you would have seen, I'm sure, before. So things like box jumps are here. So again, looking at more the force generation side of things. And then what you can start to do is build that up onto a higher box. So they're actually requiring more of that force generation and then less of that absorption stream. But again, these are real nice ways just to build these things up bit by bit. It might be, if you are doing jumps, you want to jump forward as well. So you're almost looking at sort of leaps forward, and it might be that you're almost jumping onto something if necessary. Now, the next thing with this is sort of worth considering is almost a different height. So you can build this up. You can create little obstacle courses, again, different heights of box, and look at how they demand and what the control is like. And then again, looking at the way that they land. Can they start to land onto the sort of rear foot or midfoot rather than landing in that sort of declined squat position, because that ramps that up enormously. The next thing I'd look at is this. So almost looking at them landing and then immediately transferring into another jump there. So just to show you that again, he's landing and then automatically starting to propel. How does he do that? Does he do that with a great deal of knee bend, or actually does he just do it all with his Achilles? You might want to look at this. So just basically going into a jump and then just going into different planes of motion as they do this. So again, they're jumping, and then as they land, they're starting to press off into different regions. So are they more confident as they land to push off to get back into the play, how they get on? And this is what I was talking about. So you might want to go to a single leg and look at some of the more horizontal output and look at the distance rather than just the vertical output that they have. What is their landing like? He's not very good at this stage of his condition. Now, the other thing to look at is maybe the jump analysis side of things. So you might want to use something like the LESS test to look at. So you jump to a line, land, and then look at that vertical output that's there. And what are they like impacting? And then what are they like on that propulsion? Does that expose anything that's different? If they are struggling, again, as I did at the end there, just drop into a shorter position. So 30 centimetre box, out half their body height, or they could just go to half the distance if that's something they're struggling with. And again, little things that are good measures just to measure, again, one side compared to the other. What are they like jumping one side to the other with over a line? You might want to do that again on a wider line. So again, how many can they do in a certain time period? So again, in the sort of the literature, we're looking at sort of 55 per 30 seconds in males and 43 in females as a rough guide. And that's what Mick Hughes uses in his sort of ACL rehab guide. What you might also decide to do to put a little bit more challenge on that, if they're finding that too easy or if it's more relevant to their sport, is what are they like jumping over a small hurdle or potentially increase the height of that hurdle as they do it. So again, little cues, more vertical output from there. So then what ends up happening is when you start to build in some of your sort of running drills and equivalents, you can be pretty confident they're going to be okay when you start to drip them in. So they've got that isometric control, that stickability through that muscular tendinous unit, and they are pretty happy starting to load in various different ways. Now, you can, again, sort of build that up bit by bit, looking at little plate hop in different directions, which again gives some extra confidence, or you might want to do some of these. So little double leg to single leg hops, one side compared to the other, and look for any discrepancies as they're starting to propel themselves forward. You might want to have a little look at some of these. Again, that quick transition, 1-2 sticks that you can see here. And again, what are they like as they start to open up into those positions? You can add resistance that you can sort of see here. Again, when they're starting to drive forward, what are they like as they start to go into some of those running positions, high knees, high heels, and so on. And again, lots of little other ways that you can do it and build this up. I love using ladder drills. For a lot of these athletes, it gives them certainly some little motor control things and focus to go for. Only problem is just make sure they're not just looking down as they do this, so they keep their sort of trunk height up. But again, these little small drills are really nice ways to start to build the exposure up and get them ready for running. You can do that in multiple different planes. You can do these little diagonals. And then again, what you can start to do is sort of various different variations over hurdles again, just to add some extra different stresses. You can do that again, sort of little jumps, little side steps, jumps. And again, if you have anyone who is a defender, like I am, in particular in football, these backwards little shuffles that you can see on the left-hand side there, really useful. Little bunny hops that you can see here, again, sort of all different variations that you can look at progressing the athlete depending on who you are working with. So be creative, think about what you need to mimic, and then there's all these different things that you can do. Again, the speed at which they do it needs to be relevant to what they are going to do. Does it need to be double leg? Does it need to be single? And generally, can you start to use some of those little movement patterns and build those into practice? You might decide to use some of the single leg markers that you would have seen in other topics, so things like the single leg hop. You might want to do that to different angles. You might want to be doing something like a triple hop, or you might even want to do things like the vertical jump that you see in the middle here. So again, what was their height that they were jumping at baseline, and what is it now? If you have that information, brilliant. If you don't, then again, what's it like maybe jumping off one side compared to the other? So you're exposing that individual accordingly. Now, and just to show you a little bit on the sort of ACL sort of side of things that we did with one of our athletes, again, some of these demands that you need to potentially look at recreating. Whatever they are going to do out there, try to prepare them the best that they possibly can. So again, some of these little variations that we were doing, highly applicable to something like a patella tendon. And again, these are just to give you some little ideas of some of the things that we would potentially do. So looking a little bit more at stability, lateral stepping, some of that rotational control work. Again, sort of box squats with significant amounts of weight that he's doing, but he's doing that as a front squat that you can see there. Deadlift bits and pieces. And again, that ability to drop down from this position. A lot of the rehab that you see is highly applicable to different conditions. So again, it's not exclusive, but your clinical reasoning behind what you are doing, again, really, really important. So hopefully that gives you a little flavour of some of those things that we did with this athlete. Then I just want to take you through this really. This is just a patella tendon sort of strapping.
Have tendinopathy issues around that patella. So thinking about the anatomy, obviously as it runs from that distal
pole of your patella into that tibial tuberosity, what you may find useful with an athlete is to try and almost anchor it slightly halfway between. So rather than the pull occurring into the tibial tuberosity and it tractioning and starting to get that soreness, if we almost reduce the length of that tendon artificially, then it might help offload some of their symptoms. So what we do with this, again, we're using like an EAB strapping. Try not to apply it on stretch, because when it then recoils, you may end up with some neurovascular compromise there. So find the distal pole of the patella, find the tibial tuberosity, come in between. And what I'm doing is just laying the tape on. So I'm pulling it out and then just coming round from there. Now, when I get back to the middle again, what I often find useful is to almost to create an anchor, is stabilize it with your thumb and apply a full twist. Then what you're going to do is almost push that twist into the athlete. Come back round again, exactly the same thing. So if I show you, apply the fix just about an inch or a centimetre to the lateral aspect, rotate the tape, so it's starting to build up a little almost knot device there, and then come back round again. Exactly the same thing. So no tension, apply the twist, move on to the knot, and come back round again. Now 3 times is the usual in terms of how many, and then this last one, there's no tension here, and then I actually apply it with quite a bit of tension across the front of that patella. And then what we're doing is just looking at almost rip that off and stabilise it. So that will give the athlete a little bit of support here. You may or may not want to use something like a tear-like strapping over the top just to hold it in place. So to do that, again, all this is just to try and avoid it coming off. So there's no tension on there. Fix it medially and stabilises. So you've moved the insertion of that patella tendon artificially to slightly more proximal, so there's less pull and drag onto that tibial tuberosity.
So there you go. This is just the top right hand side is just one of our athletes basically getting exactly the same thing. So this is what he had, both sides, a bilateral patella tendinopathy, which was a bit of a nightmare for him. But again, you can sort of see the exact same sort of technique, but he only wanted the old Muller taping that's on there. Other things that you can have, again, if you are struggling with a patella tendinopathy, is shockwave therapy is available. There are positives and some unresolved questions, if you like, regarding the exact benefits of it. It is proven to have a positive neuropraxic effect, have benefit in terms of sort of release of endorphins, specific growth factors. It has an anabolic role in terms of increasing blood supply. It can be that little window of opportunity again, that sort of analgesic effect, so you can then start to load that. I would never use shockwave in isolation, but if you do have a really stubborn one, it does sometimes give you a little window that you can start to load up in. The results aren't always exactly the same, and that's because there are many different machines, therapists, protocols, and they will all use their own sort of preferred methods, really. So again, to try and compare them isn't always the easiest thing to do, but just remember, it doesn't replace the solid rehab that we've just gone through there. There are PRP injections, which again do offer some relief and some benefits, where you're injecting platelet-rich plasma into that region. You can also have this stripping effect as well, which can again be shown to have really high benefit and reduce inflammation, and that can be up to 12 months. So if you have something that is really stubborn, something that's constantly tethering against it, scar tissue, inflammation, etc., that fat pad's just gripping on for just sticking into it for ongoing periods, again, that might be reasons why stripping might be an option. So really what we're going to do is go through the strength markers, make sure we've got the stiffness and reactivity back into that, gone through our running drills that you go through, and then almost drip them back into training. And once you've gone through all of those, really what we want to do is just sort of almost on a tick box criteria basis, make sure they're there or thereabouts. Now, this is important. So after you have completed that process and you've got them back into the sport that they are back into and they're playing well and they're back feeling very good, you need to avoid that complacency, which is the natural process this goes down. So you want to just make sure that you keep on at them to make sure that they keep on with that analgesic loading, make sure their recovery is good and those pre-training preparations are spot on. Reminding them again once they're back that there is still tissue remodeling that is ongoing at 3 months is important and will probably go on for considerable more months. So again, just stopping now will only sort of touch the iceberg. You need to keep on working, particularly if this is a degenerative tendon. Keep self-monitoring it in terms of VAS or NPRS scores, and then what's it like post-training, what's it immediately after training, and what's it like sort of 24 hours later or the following day. And again, what's that sort of iso strength output like, palpation, soreness, etc., are all clues that maybe it's not very happy. Keep going with those 30 to 45 second isometrics. And again, thinking about how much load goes through that, it needs to be pretty high, around that sort of 60 to 70% of that max voluntary contraction. And when do they do it? That's the question they always ask, because when do I fit this in? If I'm going to get DOMS, I don't want to do it at the start of a day. I'd usually do an initial analgesic loading program in the morning and then almost a heavy loading at the end of the busier day. So often when they've finished, they'll go and load heavy. So when they wake up the next day, they've got all their DOMS that's kicking in, and then hopefully they've got a day to recover, and then they're back in following that. Again, it might be you need to keep an eye on the conditioners that are there, because they may forget to pull this individual if you want to put caps on the amount of meters, accelerations, plyometrics, etc. they're doing. And then again, sort of testing under fatigue is something that I would do. So just periodically after a session, get them in and go through that testing. Brill. So that is it. Well done. That is the whole sort of patella tendon management. Hopefully you will have taken out of that load is absolutely key. What load is it that flared them in the first place? Do you have to deload them? Do you modify? And can you build them back in again? Can you train around it? And again, can you address those contributors proximally and distally? Build in with the isometrics in those ranges that are more confident, go into the isotonic work, and then start to get into your plyometrics once you've got those measures that you're happy with progressing on to. Do your strength checks all the way along before you start to drip in, and you should find that it's a much smoother process. And then once you go into your sport, again, try and go through a tick box criteria. And again, after they have returned, make sure you keep an eye on them to keep them off that miserable carousel of sadness that they have. So that's it. Congrats, guys. We are there. We've made it. Thank you very much for watching. I hope you feel a lot more confident with some of the ways that you may look at, sort of get excited about the way you manage these. If you are watching this in isolation, this is found on growphysio.com, which is the library of resources that are on there. There are loads of different elements of sports injury learning. Please get in touch. Please, if there's certain bits that you've enjoyed, get in touch with me. Tag me in something. Let me know how you're getting on, what you enjoyed about it. And then when you're applying it maybe into practice, give me a little tag. Usually on Instagram, I'm pretty active. So yeah, big thank you from me. Enjoy applying it. And I'll hopefully see you all soon for some more Grow Physio opportunities.
Hey, folks, well done for sticking in there. And that's a big double whammy, isn't it? Now, as I said before, I think the chat function on Zoom's not working. So if anyone's got any questions, you might have to be brave and chuck your mic on. Very happy to answer anything on the assessment parts, the treatments, anything rehab related, any sort of case studies that you guys have got. Please feel free to share them. It's basically a platform to hopefully kind of optimize your learning, really, and give you a chance to sort of reach out and network. Does anyone have anything? Or are you frazzled after a day in clinic or working in sports clubs wherever you are, or at uni, and don't have anything else? Just looks like a few thank yous coming in. That's good. You're welcome. Oh, thanks, Lorenzo. I think you guys, the chat's working, but as soon as I try and write anything in it, it just crashes. Brilliant. All right, guys. Well, what I'll do is just to kind of wrap up, I will send you through your certificates. So you'll get your CPD certificates that you can kind of keep as an e-portfolio thing. Obviously, kind of prove that you've done some additional learning. Feel free to share them. Feel free to share any sort of still pictures that you might have kind of taken. And I'll send you through the recording once it's uploaded to YouTube now. It'll probably take me about an hour to pull it all together, but I'll send that through. Thank you all for your patience earlier on. And I think Chelsea's got a question. I have a lot of issues with grassroots football, switching between grass and 4G. What would your top tip to manage this when it's mid-season? This is a real tricky one, particularly with Achilles. So what we found back in the day was when we moved from in a very wet environment in Newcastle onto 4G. If the pitch was absolutely wrecked, we try and preserve the pitch. So sometimes we chop and change in that sense. And then we also had the issue that we would basically train on grass, but then play on a 4G pitch. So it's a really tricky one. I think the only things I would say is just try to get your monitoring levels really good. So that might be monitoring in terms of kind of range of motion. It might be kind of some strength measures, but also the loading elements that are going through those individuals. So if you have access to the GPS units with the sports science team, or if you have access to them yourself, then that would be great, because then you can monitor how many sprint meters there are, how much volume mileage they're doing. And you might need to wind it down a bit. They have found that there's an increased risk of foot and ankle and hamstring related injuries when you're on an artificial pitch. So again, what can we do to mitigate that risk? I suppose going into it, is there any testing that we could do in that sort of transition period or leading up to it, so we address some of the deficits that are potentially in some of our athletes, which again, if you haven't got numbers and data, you're sort of just guessing why it's gone wrong. It might be something, there might be some real value in and around looking at the footwear changes as well. So it might be that the boots that they use on Astro or 4G, they use a different boot on grass. Exactly which boots are currently the most effective in that sense, I don't know, to my knowledge, if there's any evidence out there, but it might be worth reaching out to some sort of sports podiatrists or sports mechanists to see whether or not there's anything in the literature that might help to mitigate some of that risk. Again, I guess it depends on how much meterage they're doing. Is the stresses different astro to grass? And the evidence is suggesting it is, but exactly what to do, I would just do the things that are in your control, really. So yeah, try and get a bit of an insight into that. Any other questions at all that anyone has? I'm very happy to stay on as long as people need me, and obviously kind of feel free after this, if you're kind of watching this in retrospect, or you're watching it back, because I know there's a lot of information, you'll have access to this for at least a month, so I'll make sure that you guys can access this for as long as you need. But if you've got any other questions, then do reach out. Les has just written, I've got a runner doing a marathon in 3 weeks with knee pain in the front with some swelling and can't lock the knee out. What's your advice, if any, this late before the event? Yeah, so I mean, at this sort of latter few weeks, obviously people have generally ramped up their training, their loads increased, and then things start to grumble. I think that the thing you've got to try to, you're okay 3 weeks out. It's normally kind of 48, 72 hours out that you're in a real pickle, but I would get them probably hitting some anti-inflammatories pretty hard, just to try and hoover up any of that inflammation that's sitting in and around that region. If they've got inflammation or sort of little chemicals are sitting around there, then you might end up with some inhibition and a knee that's not able to fully lock out, which again, that's going to build up the amount of stress through that patellofemoral joint, and then they're going to get issues, aren't they? Eventually, if they're massively changing the way that they run, obviously it may well put some additional stress through tibia, through potentially areas of the foot, which might lead to stress reactions or fractures. So yeah, you really want to make sure you've got a quiet knee, the best that you can. I would say you'd probably they'll often freak out when you tell them just to rest, but just kind of go, look, I want you to work on all these other things that aren't knee related. It might be they're working on, I don't know, just give them something to do with like glute control. Might be that they're kind of working on intrinsics of the foot. They might be doing some kind of off feet CV work. They might even have, depending on how sore it is, they might have to do some seated ski erg or some hand bike stuff, or just something that's not going to stress that knee at all, because they will be freaking out that they're not necessarily fit enough. But yeah, get a quiet knee. Make sure you've got that full knee extension. So you might need to do some kind of APs or some release work through that popliteus or that gastroc, or kind of the distal end of that hamstring, just to try and calm things down. Some APs work quite nicely once all of that's calmed down, just to kind of get that last little bit of terminal extension. That'll make that knee feel much better. And then I would just play around a little bit with some K-tape, some dynamic taping options that you think. Find the movement that's really quite sore for them. So it might be when they're going knee over toe, for example. Apply some tape in, reassess it. Can you find something that helps to relieve that pain a little bit? And then just stick with that. And it might be that they bang some K-tape on for the race. There's no harm for that at all. Luke, what are your thoughts on using ice for acute flares versus NSAIDs? Yeah, I would throw the kitchen sink at it. So, and I'm a bit old school in that sense. I think if you've got swelling that's acute, then what you want to try and do is create some vasoconstriction. So if there is some local reaction, the ice that you put on, or whether you're using something like a Game Ready or a Physio Lab or whatever it may be that you're using, I think is really good to try and just almost analgesically calm things down, because you're getting some sort of sensory input that's going to make it sort of calm a bit. The vasoconstriction might well sort of reduce the amount of kind of flood of any fluid into that region, and then smash that in with some non-steroidals. I think unless there's been a real acute trauma, so like let's say something like a muscle tear or a ligament tear, a kind of tendon that suddenly massively flared up all of a sudden, I think at NSAIDs, if you've got a specific event that someone's going to do regardless, I would probably go and hedge my bets and just throw the kitchen sink at it. I know there's some really interesting research that's coming out just kind of saying that ice isn't massively effective and therefore we should be using heat. But I think when we look into some of that evidence, it's still not saying that ice is necessarily bad. It's just saying that what we originally thought, that it has these amazing impacts on that swelling process, don't exist. But I still find psychologically and sort of clinically that it does help to calm things down as part of a package. What you shouldn't do, Les, is just get them to keep going and crack on, because otherwise, if he carries on training and loading through that knee with running, at this stage all the way through the next couple of weeks and then rest the week before, that isn't ideal. So I would try and get them to calm it down first of all, and then start to kind of just build up from there, and just swap any of that impact work in that knee just for anything that's potentially off feet. Even if they're doing cycling, it's going to be a lot better for that knee to calm down than it would do if they're just plowing mileage through there. So I hope that answers them. Anything else? If not, guys, we'll probably wrap that up. I hope that's been really useful. Thank you for your questions, because it always does make it really kind of a bit more interactive, really. But if you've got any other questions on the back of that, then by all means drop me a message. My email is steve@growphysioacademy.com. I'll send you guys through an email anyway to the email that you guys registered with. If there's anything afterwards or anything that I can do to help support you, then please just reach out, let me know, and I'll do my very best to do that. All right, folks, thanks again so much for joining, and hopefully see you guys. We're doing ACLs. There's a couple of ACL webinars next month. We'll kind of plow through all of that, sort of how you plan it, assess it, the treatment bits, a lot more kind of manual therapy related techniques in that one, as well as that sort of guidance through the rehab process. So hopefully see you guys at there. And thanks to anyone who's obviously kind of members who've just jumped on tonight and non-members. If you want to find anything else out about the Grow Physio Academy and joining that, then obviously kind of just reach out as well. All right, guys. On that note, good evening. Go and relax. Put your feet up, and I'll hopefully see you again soon.